So some of you know me, some of you don't. I'm the Director of Pain Management at Maimonides Medical Center. And in the next couple of minutes, some people are still trying to log in. I just want to make sure everybody gets access before I get into the content. But just a quick introduction. I've been at Maimonides since 2007. I trained at NYU, did anesthesia there, and my fellowship in pain medicine there. And when I was a fellow at NYU, there was really nothing to study from for the pain board. So I created a board review website called PainExam, which then developed into a podcast, an anesthesia review, and hence this course. Since 2007, I've been using ultrasound in my pain practice. And since 2003, I've been using it as an anesthesia resident. And ultrasound has definitely been a game changer for the specialty, as you guys know. And it probably was one of the reasons I went into anesthesia as a resident. As a med student, I rotated and I saw Dr. Sandhu at NYU doing nerve blocks, and I immediately knew this is what I wanted to do. And I gave up my dream of being an ER doctor for the better, and went into anesthesia. So we're gonna go over this. I do, as my disclaimer, I do treat pain management in the office, not as much OR anesthesia these days. However, I did develop the regional anesthesia program at Maimonides with Mark Cronenfeld and Gary Schwartz and some other docs. But I every now and then do go back to the OR, not so often. But a lot of what I'm going to tell you today is mainly for the OR, and there is a lot that's applicable in the pain office as well. But I'm going to focus on what you guys came here for, which is the operating room. Let's give another minute. I think someone else is trying to get in. Okay, so I've also taught for American Institute of Ultrasound and Pain Medicine, WAPMU, World Academy of Pain Medicine United. I just joined their faculty. ACIP, NRAP is something I kind of coined myself. NRAP stands for Neuromodulation, Regional Anesthesia, and Pain. And you'll hopefully hear a lot more about that coming up. That's something I'm developing. If anyone has any interest in helping me out with that, I'm open-minded. I'm open to all sorts of ideas. And I do talk about this stuff a lot on the Anesthesia Exam podcast and the Pain Exam podcast. Pain Exam is a board review for pain docs. It's a CME activity sponsored by my hospital, as well as the Anesthesia Exam. Anesthesia Exam is a board review for anesthesiologists that I developed years ago, and have to admit I neglected it for a bit. So I'm redoing that now. So it's going to be up to date, and it'll be coming out in the next few months. And over the last few years, I probably helped about, let's say, over 3,000 pain doctors get their pain boards. We have these videos. Some of these videos are on the YouTube channel, Instagram, Facebook. So if you're ever looking just to review some of the content, you could go to painexam.com, or you can look at any of my other online content through social media. And of course, sign up for the newsletter so you'll get updates as to course schedules. I am doing an ultrasound course April 18th in Manhattan. The venue is yet to be decided because I may be doing this with WAPMU. If I don't do it with WAPMU, I'll probably do it on my own, but I'm pretty sure it will be with them. So they're looking for the venue right now, and I hope to see you all there. Once again, NRAP, Neuromodulation, Regional Anesthesia, and Pain. The ultrasound has changed the game for not just the perioperative care of patients for pain management. It's also enabled us to place nerve stimulators on peripheral nerves. And this is something you as anesthesiologists will probably be seeing in the coming years for perioperative pain management, where the patient will get a temporary stimulator device on the nerve to stimulate the nerve postoperatively for pain relief. And you'll be the ones to place it, not just a pain doctor. So there's also ablative techniques, which anesthesiologists are already implementing to their practices. One of the cryotherapy devices for knee surgeries, lesioning the infrapatellar saphenous nerve. So there's a lot of stuff going on with regional anesthesia, more than just injecting local anesthesia. And I think as pain practitioners, a lot of us tend to, develop our outpatient skills. And what's becoming very popular in the pain office is minimally invasive spine procedures. There may be more of a vacuum to fill for the regional anesthesiologist or the anesthesiologist to be more active in the acute pain aspect. And therefore, it's helpful to learn techniques more than just the bread and butter regional procedures. And that's what we're going to talk about today. And I'm not going to get into neuromodulation or any of those other fancy things, but I will get into some other blocks that you don't typically do or see. So these are my disclosures. I do have some relationships with industry. None of them should affect this talk. And just to quickly review acute pain management, right? Before we get into all the ultrasound stuff, let's just go over the basics. Acute pain is protective. Unlike chronic pain, you need it. You want to know when there's danger or when there's a problem so you can feel it. There is a disorder called CIPA, congenital insensitivity to pain with anhidrosis. This could be asked on the anesthesia boards. And it's part of the HSAN, or hereditary sensory and autonomic neuropathy disorders. There's a mutation in the SC9A gene, and there's a prematurely truncated protein or mRNA decay, and there's a loss of pain sensation leading to devastating disability. You've had kids who want to show off to their friends. They'll just jump off the roof and say it doesn't hurt, but obviously that doesn't really go over too well. And therefore, the children who are born with this disorder actually have a pretty short life expectancy. In terms of the local anesthetics, lidocaine, as you know, short acting, very useful, but not so great post-operatively when you want something longer term. Bupivacaine, long acting, more sensory than motor block, but the cardiac toxicity could be a problem, but we still use it a lot because it's quite cheap. Ropivacaine is expensive. There's less motor block than bupivacaine and a higher safety margin. And of course, there's the liposomal bupivacaine, which lasts about 72 hours. So for better or for worse, you need to know what you're doing when you place that. You don't want the surgeon to complain to you a day or two later that the patient is weak. So you have to know where to put that. This is a CME approved activity by my hospital. And to claim credit, just enter or text the code 75FORD to the number below. Okay, so when we're dealing with nerve blocks, let's just start with the basics. And those of you at my monitors, you've seen a lot of these slides already, but I promise you there's a lot more in the full presentation. So first symptom, a patient who has a local anesthetic toxic reaction may complain is just being disinhibited or a little obtunded. They may complain of an ominous feeling, vertigo, tinnitus, circumoral numbness, metallic taste in the mouth, breathlessness or garrulousness, tremors, and then they can progress to myoclonic jerks, convulsions, coma, and cardiovascular collapse. First thing you want to do is, of course, stop the injection, call for help. Consider lipid emulsion therapy. If the patient is with you in the perioperative setting, they are probably monitored. So therefore, you kind of have an idea as to where you stand with the vitals. It's not like it's an office setting in a pain practice. And you definitely want to make sure you know where that lipid emulsion therapy is, or the LAST, local anesthetic systemic toxicity rescue kit. Hopefully you're close to a place with a bypass machine, because you may have a prolonged resuscitation. The bupivacaine binds to the cardiac muscle, takes a while for it to unbind, and therefore you may need a substrate such as the lipid emulsion therapy for that bupivacaine to bind to. Manage the airway, ventilate with 100% oxygen, avoid hyperventilation, and you may need to intubate. Control seizures. Better use a benzodiazepine than a propofol bolus because of the hemodynamic factors. You could bottom out the pressure with propofol. Treat hypotension and bradycardia. If pulseless, start CPR, ACLS. So when someone is over 70 kilos, bolus them with 100 milliliters of lipid emulsion 20%. Do this rapidly over 2 to 3 minutes. and then infuse the drug 200 to 250 milliliters over 15 to 20 minutes. If they're less than 70 kilograms, bolus 1.5 milliliters per kilogram rapidly over 2 to 3 minutes, and then you can run an infusion at 0.25 milliliters per kilogram per minute per ideal body weight. If they're unstable, rebolus once or twice at the same dose, and then double the infusion rate. Be aware of the dose limits, it's about 12 milliliters per kilogram. The total volume of the lipid emulsion can approach 1 liter in a prolonged resuscitation, which is considered over 30 minutes. Continue monitoring at least 4 to 6 hours after a cardiovascular event, or at least 2 hours after a limited central nervous system event. Do not exceed 12 milliliters per kilogram of lipid emulsion, especially in small adults or children. And go to the ASRA website for updates. This may be changed in a few months or a year because it always does. My information is from ASRA. A lot of the information in this presentation is from ASRA, NISORA, as well as some other studies and case reports and my own personal experience. And speaking of my own personal experience, well, why we've all been in the OR when the surgeon goes to work and the nerve block hasn't taken yet or is just not working. And unfortunately, it's a very embarrassing situation, but it happens to all of us. And why does this happen? Well, there can be septa forming subcompartments around the nerves, and that can prevent the spread of the medication. There could be fascial membranes. You may be injecting in the muscle. This can happen a lot with a tap block, right? We're in the muscle plane. We think we're in the tap plane, but we're still in the muscle. You see in the scalenes, you may be injecting in the muscle body. You may not be focusing right. You may not know how to use the knobs on your ultrasound machine. You may not be getting the local anesthetic around the nerve fully. You may only be getting one part of the nerve. Some nerves are larger or have some of their fibers shielded from the local anesthetic because it's adjacent to another structure. You may also misjudge the depth of your needle tip. You might not be aligning your probe and needle properly. So here we have an image of an oblique ultrasound. Okay, the image below right here, we're looking from above, and the person doing the ultrasound is not completely in line with the needle. He's not really out of plane or in plane. He's somewhere in between. And you don't know where your tip is. On the other hand, you have an intentional out of plane injection, and you don't know where your tip is. That's the problem with out of plane. Now, out of plane is very useful for many procedures, especially when you can't really get the whole length of your needle in the ultrasound screen. However, I recommend, generally speaking, out of plane for the more advanced interventionalists or anesthesiologists. Brachial plexus, as you should know, is divided into the interscalene, supraclavicular, infraclavicular, and axillary regions. Roots, trunks at the interscalene, divisions at the supraclavicular, cords at the infraclavicular, and nerve branches at the axillary. And you can see here, I've highlighted in blue the fibers that are covered when you do the nerve blocks in certain regions. So in the interscalene fossa, you're not getting C8 and T1. Therefore, you would never use this block for something that is for a surgery in which C8 and T1 need to be covered. For instance, something involving the ulnar nerve, because ulnar nerve gets fibers from C8 to T1. But the supraclavicular is pretty comprehensive. The infraclavicular is comprehensive with a couple of exceptions, which we'll get into soon, and so on with the axillary. Any questions up until this point? Just put them in the chat box if you can. Okay, I'm going to just do a quick check, see if anyone's stuck trying to get into the presentation. Looks like we're good. Okay, moving on. So the interscalene block provides anesthesia of the shoulder, lateral clavicle, acromial clavicular joint, proximal humerus, elbow, but it spares the ulnar nerve. In my practice, and remember, I'm a pain physician, mainly I'm doing pain management. I'm using the interscalene nerve block for brachial neuritis, shoulder pain, frozen shoulder. And as an anesthesiologist, we're doing this for any surgeries of the shoulders typically, or anything in the upper extremity in that distribution that I discussed previously. Now, in the past, when I was in training, I remember being in the OR and my attending was doing the paresthesia technique. This is 2003. Now, we had ultrasounds back then, but it wasn't, I guess, the most common. It was just they were just starting to integrate the ultrasound in. This was my first year of training, 2003. I remember we used a blunt needle and we were doing the paresthesia technique. We had the nerve stimulator. I don't know why we didn't use it, but my attending wanted to use just the paresthesia technique. And you go into the groove and you just poke the nerve and you hope for the best. You hope that there's going to be paresthesias and you could aspirate, inject, and that you don't damage anything. But you can imagine this is not really the best practice, especially when we have the ultrasound. Then we went on to using the nerve stimulators, and the nerve stimulators, I remember being at Joint Disease as a resident, they were using the nerve stimulators. Dave Albert was there, and these guys were very slick with it. They didn't get the ultrasound around. I mean, I was there when they just got the ultrasound, so the residents were teaching the attendings how to use the ultrasound because it just wasn't part of their flow. And the docs at Joint, they were super efficient, super quick with the nerve stimulator. But you can imagine, even though that they were great with that, the ultrasound probably saved them time and also reduced the amount of local anesthesia that they would need to do their shots and hopefully reduce the amount of complications. So moving back to the interscalene block, now this is a parasagittal view. You're looking at the patient cut in half and then just scanning just off to the side, like right here. Not the typical interscalene view. This is just for educational purposes. So you're just seeing how close you are to the vertebral artery, the dome of the pleura, the dura covering the cervical spinal cord. The cervical spinal cord is not shown here, but it's very close to where your needle is, relatively speaking. Carotid artery and IJ. It shouldn't be that close, of course, but it's close enough that there have been cases where the local anesthetic has tracked posteriorly to the spinal cord or to these blood vessels. Okay, so here's a picture of the the interscalene brachial plexus. C5 is usually the most superficial, then C6 and C7. Okay, here's an image of scanning to find it. So right now we're in the neck, and watch the probe move as well as we do this. Okay, we're scanning downwards towards the subclavian or supraclavicular brachial plexus region. And we're imaging that, and you'll see how the nerves appear above the vessel, and they change in appearance as we go back up the neck towards the interscalene fossa once again. When you can't find the interscalenes, the best things to do is to find the supraclavicular fossa and brachial plexus, or find the carotids. Okay? You have your anterior scalene muscles and the nerves, they line up very nicely between this. So you could feel on yourself, it's a pressure point. It's an annoying spot to touch because the nerves are very superficial. One other thing that helps visualize the interscalene brachial plexus is just to angle up a little bit like this. You could find it and then just angle up. So using the ultrasound, I'm sure the docs I trained with learned that there's less need for repeated passes, hence the less of a risk of traumatizing the tissue. You could see the local spread around the nerves to make sure you're in the right spot. You could also tell the difference between a blood vessel and other structures that may be hypodense or hypolucent or appear black, such as your local anesthetic or other fluid collections. Now, another way to locate the brachial plexus is to find the midline of the neck, scan to the side a little bit, find the thyroid, and move laterally to get the carotid. Further lateral, that's sternocleidomastoid, and behind it, you see the nerves starting to line up. That's your brachial plexus. Here we're following the nerves back towards the neck. That's the cervical foramen. Okay, they're black nerves, so it gets a little amorphous over here. It doesn't look circular or linear. It just gets black. And that's because the nerves are not taking a straight path. So they're not going to look exactly like circles. Okay, once again, just get this image into your brain as to what the nerves look like, how they look lined up close to the skin. You want them to be perpendicular. There are variants in how this appears in some patients. I have one coming up, I'll show you. The nerves, the C5 and C6 nerve can pass into the belly of the anterior scalene muscle, just like the piriformis. The sciatic nerve can sometimes be actually in the muscle or through the muscle. It can occur here, and this would appear as a black hole in the belly of the muscle, the anterior scalene. It will look like a blood vessel. So put some Doppler on it, make sure there's no color and no flow. And you could direct your needle to it and inject a few milliliters of local around it. There's no other way to get this unless you scan more proximal before the nerve enters the muscle, which that case should be very close to the cervical spine. And if you're not doing this for some interventional pain, I don't see any reason why you would do that. So speaking of interventional pain, I am integrating my anesthesia blocks into my pain practice. So when a patient comes to me with cervical radiculopathy and they have sensitivity in the interscalene fossa or the supraclavicular fossa, I'm doing an interscalene block in my office. I'm giving very little local and I'm diluting with saline. So I've never seen a complication from doing an injection in this region, no phrenic nerve paralysis, nothing. And the patients get relief. And because of this, I'm able to avoid cervical epidurals in these patients, which I do cervical epidurals, but I probably do a smaller percentage than most pain doctors with the same volume I see, because I don't need to do a cervical epidural. Just to give you an overview, cervical epidurals help, they work. They're great for patients who fail conservative therapy. However, you're so close to the spinal cord, if you can reduce the pain by less invasive means, and less invasive means a nerve block outside the spine, then why not? So that's what I do. Okay, this is one of those variants I told you about. So this is a gentleman who actually came to my pain practice. He had cervical fusion, anterior and posterior, tons of hardware in his neck. He presented with atrophy of his left arm. He had tunnels over his interscalene fossa, just pain in the neck, shooting down the arm, chronic pain. His neck's been filleted open from behind and from anterior. So he was a real big guy, and his neck was very wide. And you see there's a lot of soft tissue, or hypertrophied, or muscles out to the side, and how deep this interscalene fossa was below the muscles. It's because his anatomy wasn't normal. He's had surgery here, so things looked a little different. And I did this for chronic pain, not for surgical anesthesia, but it's the same concept. If he came to you for a shoulder surgery, this is what you'd be looking at. You'd be looking at the nerves much deeper than they should be. And you just need to keep that in mind and look at the whole patient and kind of get an idea as to what's been done to him and why he may have this appearance, and just safely go through this extra muscle layer to get to your target. Here are the nerves coming in from this side, the needle's coming in from this side. Now in my pain practice, I use a 25 gauge 3.5-inch needle, spinal needle, for a lot of these shots. I'm not telling you to do that. In fact, I think you should use a blunt block needle. I think that's better in the anesthesia world. The reasons I do this in the pain world is because I find it to be less painful. And I'm not typically sedating patients for these procedures. You have the luxury of having Versed, fentanyl, or even propofol if you need to do it for these blocks. And therefore, it could help you keep the patient comfortable when you're doing the procedure. Okay. So the supraclavicular block, this may anesthetize the shoulder, but it really depends on where you catch it. Are you getting the suprascapular nerve or not? You are going to get the axillary nerve, so you will provide some shoulder anesthesia, but you probably will need to get the suprascapular nerve separately if you want to do a supraclavicular block for a shoulder surgery. But unlike the interscalene, you'll get the whole hand. You get the ulnar, median, and radial nerves. And in case you're interested, the CPT code is 64415-76942. 76942 is the ultrasound code for ultrasound guidance. So when you're doing these blocks, I'm sure most of you are already aware of, if you're doing them, you need to capture an image of the needle next to the nerve on the ultrasound. Easier said than done, because when you're doing a block, you're not really thinking about saving the proper image. You're thinking about taking care of the patient. So sometimes you may or may not get that image with the needle next to the nerve, but at least have something that you could show the billing company or the insurance companies in case you're audited. So the subclavian artery is the most important landmark for the supraclavicular brachial plexus. The insertion of the anterior scalene into the first rib lies between the vein anteriorly and the subclavian artery posteriorly. On ultrasound, the vein is well forward of the artery and is most time hidden below the clavicle. So this is just, I call this the hybrid view, meaning it looks like it's an interscalene, yet it's sort of a supraclavicular. So I'd say it's more of a supraclavicular. However, the nerves here are lined up like interscalene. Nice, you have your ducks in a row right here. So it's kind of that transition point, I call this. So when you're doing the interscalene and supraclavicular, it's not going to look like this. This is really that mid zone between the two blocks. Or you actually may be in the interscalene region if you look at my line over here, but you're just not angling the ultrasound to see it in that fashion. This is just a cut. This is not an ultrasound image. Okay, see the nerves here? This is how they typically appear. They're not lined up like that in the supraclavicular fossa. They're just more of just a bunch of grapes. Here's the subclavian artery, hypoechoic, meaning black. Here's the first rib, hyperechoic. And here's just a little video of how I do this in the pain office. This is not how we do it in the anesthesia world because my patient is sitting up. You could do it that way, but I caution you because I'm not giving large doses of local. So I wouldn't like to give him 20 mLs of bupivacaine and have him sit up for that. I would lie him down for that. Here I'm giving about 3 or 4 mLs of dilute bupivacaine to anesthetize him for a shoulder bone marrow aspirate procedure. So this is like I'm giving regional anesthesia here. This is not really a pain block. I'm doing it for regional anesthesia because this surgical procedure is actually an injection of bone marrow aspirate into his shoulder. But I don't need large volumes here. So I'm giving him the 0.25% bupivacaine, and you could see when I'm approaching from behind like this, I'm not aiming at his lung. His lung is down here. So in my opinion, this is way safer than they're teaching you to do this in the operating room, with the exception of if, God forbid, this patient vagals and falls. But then again, we do epidurals with patients sitting up all the time. So why should this be any different? You're looking at the imaging and you're making sure you're not injecting that into a blood vessel. So it's arguable. However, it's not what people are doing. Nobody's really doing this block sitting up. No one I know is. And if I had to put a patient if a patient was going for surgery and needed 20, 30 mLs of local, even 30 is a lot in this area, maybe 15 to 20 mLs in the supraclavicular brachial plexus, I don't know if I'd sit him up like this. Maybe I wouldn't, and I'd just give it slower. But it's very easy to do it this way. And I find it to be a lot safer because you're aiming anteriorly and not at the lung. So the supraclavicular block's pretty reliable. You can usually get a comprehensive block with minimal redirects of the needle. You're avoiding, for the most part, you still could get some phrenic nerve paralysis, but it's not as much to the extent as the interscalene. The interscalene has a very high rate of phrenic nerve paralysis when giving large amounts of local. Once again, like I said, I never seen anyone complain of shortness of breath when doing an interscalene block in my office with just 2 or 3 mLs of local. So you have to be careful if the patient is suffering from COPD or has some other respiratory problem that could compromise them. For procedures of the upper arm and elbow, the block is a simple alternative to the axillary approach. Even with the ultrasound guidance, like I said, very few redirects are necessary. And once again, you're looking here, you see the nerves and the arteries over here. Here's the rib. Okay, in case you forgot how to read x-rays, this is a pneumothorax. Notice the absence of lung markings out to the side. In the pain office, I'm doing these blocks once again for patients who present with brachial neuritis, and I'm using it to anesthetize patients for other procedures. I am using dexamethasone quite a bit for my blocks to prolong the effect. From the literature I've read on it, beyond 4 milligrams is not beneficial. So I wouldn't give more than 4 milligrams for nerve blocks. And I'm using 0.25% bupivacaine. Sometimes I'm diluting it. Ropivacaine would be great. We just don't have it available in my office. So just some tips here. You can keep the lungs out of the way by just keeping, you can stay away from lungs by just basically keeping everything in plane, seeing your lungs, seeing your needle, seeing the nerve, the target, just knowing where everything is. Go slow, take your time. And once you get to the brachial plexus, inject slowly in the area. You don't want to inject too quickly, and because that can maybe increase the risk of wasting your local in the wrong spot, or maybe if you are in a blood vessel or near some open venous sinus veins or anything, just a high pressure injection could cause possibly some more damage or side effects that we just don't want to deal with. We have enough problems. Gary, did you have something to add? Sorry, I just noticed that. I unmuted you. I saw you have a hand raised.
Sorry.
Okay. Okay, so when you're when the infraclavicular nerve block, this is something I trained on, and when I was at Bellevue.
Raise hand by mistake.
Let me mute you because I could hear you. Okay. So the infraclavicular block, we did this for a lot of the vascular reimplantation surgeries when patients would get their hands chopped off working in the garage. These 12-hour, 24-hour surgeries. We would bring them to the OR. The senior resident would do the block, and the junior would get stuck watching the patient for 12 hours if they were on call, 20 hours. I mean, it was miserable. And the nerves we would go for would be the infraclavicular brachial plexus block, because this is a region that is a great place to put a catheter. It's a very stable spot where the catheter won't move, and you can put the catheter in one location and reliably get anesthesia of all 3 cords of the brachial plexus. In addition, there was a very low uptake of local anesthetic in this region. We would give 20 milliliters of lidocaine mixed with bicarbonate and epinephrine, 2 syringes worth, 2% lidocaine. We're talking 800 milligrams of lidocaine being injected within 5 to 10 minutes into a patient's brachial plexus. According to the books, that's a toxic dose, right? With epi, 4 to 7 mg per kilo or 7 to 8 mg per kilo, we're talking about 500 and change, 560 milligrams should be your max. We're going way above that. And the only toxic reaction I even heard about was when they did a block on the dwarf, and that was before my time. I don't know what they gave him, but this has been shown, and I'm not telling you to do this because I wouldn't advocate giving anything more than toxic doses, but this is what we were doing routinely, and we never had any issues from it. And the reason is because this area has a very low uptake of local anesthetic. We would do this block for surgery distal to the shoulder, elbows, forearms, wrist, and hand. Now, I remember when I first started Maimonides, Dr. Gupta is the doctor who runs the floor, and he gave me one of my first cases was an upper extremity case. I took the ultrasound, I put it here. At the time, I took an epidural needle because I didn't see the block needles there, and this is what we used at NYU anyway. And I took the Tule needle and I just went in right here with the ultrasound, and people kind of looked at me like, what about pneumo? Aren't you worried? And you're very far lateral to pneumo. It's not really, It should not be an issue. Of course, it's an issue if you really don't know what you're doing, or if you're not visualizing the tissue properly, or if you're not lateral enough, if you don't know where your needle is. But if you know where your needle is, you know where the nerves are, you know where the lung is, it shouldn't be an issue. I never even heard of a case at NYU when we were doing this of a pneumothorax. It was very easy block to do, pretty easy to set up. The CPT code, in case you're coding this, is 64415, like all the other brachial plexus blocks, and 76942 is the ultrasound read. This slide is meant to kind of go over whether or not you want to use a high or low frequency ultrasound. Now, in this area, you don't always need a low frequency probe or a high frequency probe. The advantage to the low frequency probe is if your patient's big, you're going to see the tissue better because low frequency is more applicable for the deeper structures. If it's more superficial, then you want to use the higher frequency. But the problem with the high frequency probes is that they're usually flat. The advantage to a round curve probe is that you can get between the clavicle and your probe very easily. And that's how we were doing this when we did this block with a curved probe. Now, looking at the imaging, the chords are hyperechoic. The lateral cord is commonly cephalad. The posterior cord is posterior to the artery. So here's the lateral cord, here's the posterior cord. And then the middle cord is right here. And this is seen between the artery and the vein. Okay, once again, the artery is more pulsatile. The vein may be collapsible, but can be bigger than the artery. Now, when we're going in with the needles, that's our target. We're going right below the clavicle, above your ultrasound. We would typically take the needle, aim for the medial cord first, make sure you're in the sheath and that the local is spreading around the nerve. So it should be some blackness spreading here. Pull back the needle, redirect, aim to the lateral position, and anesthetize the lateral cord of the brachial plexus. Then we would scoop up carefully, not traumatizing the nerve, of course. We were using a blunt needle for this. Then get to the 6 o'clock position of the artery and anesthetize around the posterior cord. This is also where we would place our catheter. After we would place our epidural catheter, or our nerve catheter these days, we would inject 2 or 3 mLs of air in this region to verify that we're getting adequate coverage. And you can see the air spread in this pocket right around here, and make sure that you're getting coverage. Now, we've also done in the past, there were times when the surgeon would need to reevaluate the patient after surgery, their nerve function. So we would reverse this. We would just inject saline into the catheter. It would wash away the local to hasten the effects of the drugs wearing off. Okay, so comparing, this is an old low frequency. This is the one I used to use at Bellevue. So it's really, this is like over 10 years old versus a newer higher frequency. So it's not really fair to compare these two ultrasounds, low versus high. But I guess the real purpose of this slide is to show you the curved view, how things will look when it's curved, okay? So here's your medial cord, that hyperlucency, posterior cord, lateral cord, but you have more room to come in because it's a much smaller ultrasound probe. The axillary brachial plexus block, okay, some physicians are going in the arm. You can go more distal, but typically we're looking in the axilla, right? So the medial, radial, and ulnar nerve lies around the axillary artery. The radial artery is deep to the axillary artery. I should say the radial nerve, excuse me. The radial nerve is deep to the axillary artery. This is a board question, okay? It's not the radial artery. The muscocutaneous nerve is usually easy to find. It's in the carcobrachialis muscle. Okay, cross section of the axilla, you see the radial nerve deep to the artery. The median nerve is here, and the ulnar nerve. The axillary nerve block is performed very commonly because it's fairly easy to do. You just need to make sure you get all the branches, and you need to get the muscocutaneous nerve, which is in the carcobrachialis muscle, superior to the pulsation of the axillary artery, 90 degrees to the skin. So when I used to do this, before ultrasound, we would palpate the artery. We would aspirate blood When you go past the artery, the blood aspiration ceases and you would inject, getting the radial nerve, pull back, aspirate the blood again, pull back a little more. When the aspiration ceases, you would inject more. Of course, it would be harder to get the coracobrachialis muscle identified and the muscocutaneous nerve, so we would do a cuff of anesthesia on the upper arm and you hope for the best. But now with ultrasound, you have a lot more options. Okay, so this is the position. Patient would be lying down, hand out to the side, and you put the probe right in the axilla and you go superior to the probe or more superficial. Remember, the artery will collapse with pressure. Lateral to the artery, you have the median nerve. On the other side of the artery, deeper to the artery is radial nerve once again, and the ulnar nerve lies more medial. Here's a quick video. And there's a muscocutaneous nerve. Okay, so the image of the ultrasound on the model in this picture is not completely exactly how I would do it. It's more like this, not really like this, okay? So you're coming in like this. I'm not sure if you see that. Okay, once again, the humerus is the bone, hyperechoic bone with the darker shadow behind it. Here's my needle. The muscocutaneous nerve is over here. Okay, this is just an overview of the nerves in the upper extremity. Okay. Keep in mind, here's your lateral pectoral nerve. Okay, we're going to talk about that later when we get into the PEX block. Coracobrachialis muscle. The medial pectoral nerve also is something we're going to discuss with the PEX block later on. Muscocutaneous nerve, coracobrachialis muscle under the biceps here. And then the brachial plexus, some people are anesthetizing it in the mid-axillary, in the mid-humerus region for various reasons. You have here the radial nerve coming down, running under the brachioradialis muscle. You have the median nerve running next to the artery in the cubital fossa. This is a nerve that gets injured when people are doing IVs. I've seen some cases of CRPS from that, or complex regional pain syndrome. Here's the ulnar nerve, which can be entrapped. We'll get into all that very soon. Okay, so the radial nerve leaves the axillary artery with the profunda brachial artery in the axilla to innervate the triceps muscle. The profunda brachial artery follows the radial nerve as it moves from the axillary artery towards a spiral groove of the humerus. Remember, in that spiral groove, when you have a humeral fracture, the radial artery will typically be damaged. Okay, that's a common board question or USMLE question. Radial nerves from the posterior cord of the brachial plexus innervates the extensor supinator muscle group and provides sensory innervation to the posterior aspect of the elbow, forearm, and hand. So if you were to code this, you're going to use a 64450 code, which is a other peripheral nerve block code. Now, most anesthesiologists don't really code directly themselves. However, it's just something that perhaps would be good to know, because you never know when you might be doing that. Okay, the radial nerve lies next to the radial artery. Okay, and that was at the wrist. Here is at the forearm under the brachioradialis muscle. Okay, now as an anesthesiologist, these are not common blocks you're performing, these peripheral nerve blocks. However, every now and then you may get a patient who had surgery of the hand and maybe your block wore off and they're still having pain. You could consider maybe you want to inject something longer acting for postoperative pain in these regions. You could do this in the recovery room, or you could do this preoperatively, depending on the situation. But it's just good to have a general idea of all of these nerve blocks, because you never know when you might need it. And it would be a shame to have to supplement, to have to put a patient to sleep and intubate them when maybe you did a brachial plexus block and they're missing one branch that you could easily supplement. So the median nerve, superficial to the axillary artery in the axilla, it crosses the front of the artery from lateral to medial, can be displaced to either side of the axillary artery with transducer compression. It's from the medial and lateral cords. There's no branches to the arm. It passes into the forearm between the heads of the pronator teres. It gives off palmar cutaneous branches, passes below the flexor retinaculum. In the cubital fossa, we would call this a peripheral nerve block at 64450. But if you do it at the carpal tunnel, then it would be 20526. Now, normally surgeons would like to do their own carpal tunnel infiltration themselves. However, a lot of them do this blind, which doesn't make a lot of sense to me, but this is why I notice, or at least used to notice when I used to do the hand rooms. So it's just always good to know how to do these things. So carpal tunnel syndrome, you're looking at the median nerve. This is a little proximal to the carpal tunnel. That's why it's so superficial. You don't see the flexor retinaculum above it here, but you do see flexor carpi radialis, flexor carpi digitorum superficial, and profundus tendons. The profundus are deeper and the superficialis are more superficial. The nerve is flat with fascicles. It could look a lot like the tendons. So you might want to ask the patient to wiggle their fingers to differentiate between them. Here's just an injection where I'm hydrodissecting 25 gauge, 1.5 inch needles. It's a very sharp needle, so you have to know what you're doing. You do not want to stab this nerve or inject into it. Okay, I'm just hydrodissecting to create space for my needle here. That's all I'm doing, hydrodissecting. And then I come above and I inject it with lidocaine or bupivacaine. There you go. The ulnar nerve arises from the medial cord of the brachial plexus. In the upper arm, the ulnar nerve usually lies between the axillary artery and the axillary vein. It would be 64450, 76942 would be the code. Okay, we see ulnar nerve transposition is a surgery you've probably been a part of because when they're trying to take the nerve out of the cubital tunnel, give it some space because it's being impinged there. Okay, typically the pain will radiate in the ulnar distribution down the side of the arm. Imaging the ulnar nerve, okay, you're going to look with the ultrasound to get a cross section of the nerve at the tunnel. Here's a cubital tunnel, you see the bone, and that's the actual ulnar nerve. And here's my needle. See the bevel so clearly? It's a very superficial injection, that's why. And once again, I'm using a 25 gauge 1.5 inch needle. I would recommend you to use a blunt needle. Ulnar nerve is echogenic, triangular, or oval in shape at the distal to the elbow. It joins the ulnar side of the ulnar artery in the forearm, where it's surrounded by the flexor digitorum superficialis and profundus and flexor carpi ulnaris muscles. In the distal forearm, the ulnar nerve will lie adjacent to the flexor carpi ulnaris tendon. So the nerve can actually get entrapped. This is more of a chronic pain than a regional anesthesia point, so I'm not going to spend too much time on it. And at the risk, okay, you see the ulnar nerve right next to the artery. Okay, suprascapular nerve block. This is a great block to do. I use this a lot in my pain practice, and you can use it in your anesthesia practice. So some relevant anatomy. You have the supraspinatus muscle, the infraspinatus muscle, teres minor, teres major. It looks like we have a question here. When performing an ulnar nerve block for chronic pain, do you inject the cubital tunnel or prefer proximal to avoid further compressing the nerve in the tunnel? Great question. I usually go a little proximal, not distal. It's harder to go distal because then that's after it bends at the elbow. But I usually would go proximal. You have to look where you have enough room to work. You're absolutely right. You don't want to compress anything further. However, sometimes you do need to go where as close to the impingement as possible. So I use low volume and I inject slowly. If there's pressure, I don't inject. If it's a difficult injection, I don't. It has to go smooth. Thanks for the question. Okay, so here's supraspinatus, infraspinatus, trapezius is the large diamond-shaped muscle coming over everything. Okay, the suprascapular nerve comes off the brachial plexus, goes past the notch of the scapula. Now, I'm not even going to talk about that notch today. That notch is something you can use for ultrasound guided injections. I don't. A lot of people used it for blind injections as well. I'm not really interested in it because I get the suprascapular nerve more distal, right where this arrow point is, okay? The nerve, it's underneath the spine of the scapula. It's deep to that over here. But it runs down by the base of the spine of the scapula, and it loops around, innervating the joint, sending fibers to the infraspinatus. It already sent fibers to the supraspinatus muscles, okay? And when you put an ultrasound probe, you rest it on the patient. This is like a shelf. The spine of the scapula is like a shelf, and you're just putting your probe on it. You're able to see the trapezius muscles, the supraspinatus muscle, the scapula, the transverse scapular ligament, and the nerve is under it. The innervation, the suprascapular nerve innervates the infraspinatus muscle, the supraspinatus muscle, essential portions of the capsule and ligaments of the shoulder joint. It does not have its own skin supply, unlike the axillary nerve, which we'll talk about soon. Okay, so once again, you're putting your probe on the shoulder. And I look at the spine of the scapula more or less as a shelf. Okay, you want to have this bone at the bottom, and the nerve is going to be an oval in the corner. Okay, here's some other anatomy: teres minor, teres major, infraspinatus, and then the nerve is coming like this. Okay, here's a shoulder joint. So here I'm using a high frequency ultrasound probe and 25 gauge 3.5-inch spinal needle. I'm passing the needle through the muscles, past the transverse scapular ligament, and I'm injecting. So this is in the pain setting. However, in the anesthesia setting, it's very useful as well. For instance, they did an interscalene block. It's wearing off, patient has shoulder pain. Now, of course, if there's dressing in the way, that's a problem. Patients will have weakness after this block because of the innervation of supraspinatus and infraspinatus. This is a great supplemental injection. This is great if you're called for a pain consult in the hospital and the patient has shoulder pain. Maybe they had a stroke, maybe they had surgery, maybe they're just lying in bed forever. They're not using their body properly. Shoulder pain is something that you can get if you're not practicing good posture, right? If you're not stabilizing your scapula with good posture, if you're doing this all the time, like we all do when we're typing or doing our work, you can be predisposed to having shoulder pain. So patients who are in the hospital, they're not exercising, they're not mobile, they have all sorts of secondary iatrogenic pain syndromes that can occur. You don't need steroid to give long-term relief to supraspinatus, to a shoulder pain condition when you do a suprascapular nerve block. So even just a lidocaine or better, a bupivacaine 0.25% shot can give these patients long-term release. There was a study I remember reading years ago from ASRA, from Regional Anesthesia and Pain Medicine, where the patients had 18 months of pain relief from just a bupivacaine injection without steroid. So you could do a lot of good for these patients. You could also facilitate rehabilitation. Here's just another image of the nerve with the ligament tented upwards. The supraspinatus muscle and tendon is over here. So the CPT code for this is 64418, ultrasound 76942. In the pain practice, I commonly use the codes for right and left shoulder pain. You could use for the operating room, whatever the surgical indication is, or acute postoperative pain, or just whatever is necessary, depending on your situation. Once again, I like the 25 gauge 3.5-inch spinal needle. It's sharp, so possibly you may be taking a risk with respect to nerve trauma, but I've done thousands of these and I've never seen a problem. There's plenty of evidence for managing hemiplegic shoulder pain, frozen shoulder, shoulder arthritis. Once again, you don't need steroids, or if you use steroids, you don't need large doses of steroids, unlike a shoulder joint injection. It can help with range of motion exercises. The axillary nerve is not something I've done much as a anesthesiologist or even as a pain doctor until recently. And when we're looking at the axillary nerve, we're looking at the quadrangular space. That's our place to find it. It's basically a window here. You have the humerus of the shoulder, triceps tendon on this side, on the lateral aspect. Medially, You have the teres minor. I'm sorry, you have the triceps, the short head of the triceps tendon, as well as the teres minor. And inferiorly, you have teres major. Motor, you have the deltoid, long head of the triceps, teres minor muscles. Sensory, it's the shoulder joint as well as skin on the inferior region of the deltoid called the regimental badge. It's like where a soldier would have a patch basically right over here. And this is the superior lateral cutaneous nerve branch of the axillary nerve. Okay, the nerve has different appearances because it's bifurcating here, or it's spreading out. So you're not seeing just a pure cross section of the nerve. Some branches are going to the humerus more laterally. Some of them are going medially to the muscles that it innervates. So there's a little video on the axillary nerve. The quadrangular space is made up of the teres suprascapularis, teres minor, lateral humerus, inferior the teres major. And I'm just scanning longitudinally on the humerus right here, the humeral head, just sliding medial and inferior. You see the shaft of the humerus over here, and the teres minor muscle comes into view. Here's the triceps muscle. Going more medial, you see the teres minor again with the teres major below it. And between them is the axillary nerve. And next to it, you have the blood vessels. Okay, the blood vessels are a clue for many nerves. Many small nerves especially will run next to blood vessels. Okay, so before we take a break, I'd like to know if there's any questions, comments, or anything. Okay, so let's resume around 11:15. I'll see you guys soon. Thanks. Welcome back. Before we get started on the lower extremity, are there any questions? Okay. So when we talk about the lower extremity, of course, we need to discuss the lumbar plexus because that's where everything originates. So you have three main terminal branches of the lumbar plexus: the femoral nerve L2 to L4, which is the largest, of course, the obturator nerve L2, 3, and 4, and the lateral femoral cutaneous nerve, which comes from L2, 3. When doing blocks of the femoral nerve for regional anesthesia, typically we're talking knee surgeries, patella repairs, anything that's involving the anterior medial thigh or the medial aspect of the lower leg. In the pain management world, we do this for peripheral nerve stimulator trials, femoral neuralgia, which I've seen from patients who maybe went from vascular procedures and they the surgeon, when he went to cannulate the femoral artery or vein, he accidentally did trauma to the femoral nerve. Patients who have knee pain, we've used femoral nerve blocks for, just like in the anesthesia world. Of course, amputation pain below the knee or even above the knee, the femoral nerve can be helpful for that. When talking about the appearance of the femoral nerve, it's classically next to the artery, right? Navel, nerve, artery, vein, empty space lymphatics. And the nerve lies deep to the iliopectineal arch and overlying the groove between the iliac and psoas muscles. There's two layers of fascia between the skin, superficially the fascia lata and deeper the fascia iliacus. No muscles overlying the femoral nerve at its top position in the thigh. The nerve will send branches laterally soon after passing under the inguinal ligament. The first branch usually innervates the sartorius muscle. And when doing a femoral nerve block, if you are coding, it's 64447, 76942. First, locate the femoral artery and the vein, then examine the space lateral to the artery. The nerve is typically roundish or oval or bright, and it will have dots inside which are fascicles. Now, just as an aside, when I was doing a lot of inpatient acute pain, I remember having a patient with cancer pain. He had a GU malignancy, I think it was his bladder, and it metastasized. He had inguinal lymph node infiltration, and that mass or that swelling there obstructed lymphatics or the venous drainage of his leg. The leg affected was about 2 to 3 times the size of the leg that was not affected. And what I did for this patient was I actually I did the femoral nerve block because he had pain in that distribution, but I mixed steroid with the local and I actually intentionally missed. And I went past the femoral vein towards that empty space by the lymphatics. And I just did some interstitial injection. And what happened was the steroids reduced the swelling so much that the lymphatic drainage improved. And the swelling of that leg within a few days went back to the size it originally was. And this was a case report that we published. I've had similar experiences with patients with lymphedema in the axilla after mastectomy and lymph node dissection. So here's the femoral nerve over here. Okay, this is a interesting patient who presented to me after surgery. She couldn't move her knee. She couldn't hyperextend. She had a fracture, and the surgeon did a distal repair of the patella and I think some of the tendons as well. And the surgeon wanted a femoral nerve block for improved rehab and to maybe break up the contractures and help her move her knee. Manipulation under anesthesia, we call it. And I did that, but when I put the ultrasound over the typical spot where we go, I noticed that you had the femoral nerve next to the artery in its typical appearance with branches over here. And I thought this is a great patient to kind of go over the difference between the femoral nerve block and the fascia iliaca block. So here you have the needle coming in, and I'm doing the nerve block, but I'm actually getting more of these fibers of the femoral nerve right here. One may consider this a fascia iliaca block because I am below the fascia iliaca. Okay, here you have clear nerve fibers as well as some hyperdense tissue here. So basically the nerve has bifurcated or split, and I'm getting mainly the deeper branches, which was enough for this patient. This wasn't a surgical case. This was a case for postoperative manipulation under anesthesia. The patient got very good relief from the nerve block and was able to flex her knee all the way and do all the exercises. There's my needle tip. Now, just as an academic note, or just to kind of go over the aspects of the fascia iliaca, one could place the needle in past the fascia lata and the fascia iliaca, and it's anesthetized here, and the medication should track around to the femoral nerve. And that's the theory behind the fascia iliaca block. You're not directing directly next to the nerve. It's a fascial plane block. So the fascia iliaca, the probe is typically medial to the ACES, it's anterior superior iliac spine, maybe a little bit inferior. Landmarks, you draw a line from the pubic tubercle to the ACES. Now, this is the blind way I would do it back, but it gives you a good starting point also for where to put your probe. Divide this line into thirds, and then take the lateral to mid-third point right over here, and that's where you want to insert your needle. Usually a blunt needle if you're going in deep without the ultrasound. You want to feel 2 pops. First pop is fascia lata, second one is fascia iliaca. They call it fascia iliaca because it's covering the iliacus muscle, right? It's a fascia over the iliacus muscle in which some of the femoral nerve fibers reside. So I worked with the Maimonides ER. We were involved in a multi-center trial. I'm not sure if Monty was involved with this. I know Sinai was, in which there are patients who had hip fractures, which we see a lot of in my hospital. And we were doing a fascia iliaca, the ER was doing a fascia iliaca block, and then the anesthesia team would come and place a femoral nerve catheter. And there were all sorts of branch off studies from the study. So basically, they all showed you could reduce pain, reduce morphine use in patients who suffer from hip fractures. And therefore, it's become pretty standard in a lot of places to perform fascia iliaca nerve blocks or femoral nerve blocks for patients who suffer hip fractures. Okay, the saphenous nerve is the branch of the femoral nerve. It innervates the knee and medial lower leg to the foot. This is a nerve block I was doing for a while before so my practice, I started doing pain maybe a half a day a week, build it up to practically full time. But when I would get patients, I don't know, 10 years ago in the office, failed steroids, failed viscosupplement, they didn't want knee replacements or surgery. So what do I do with them? So I'm like, well, the saphenous nerve does go to the knee, the infrapatellar branch. Maybe I could just block that and give them some relief. And I found by blocking the saphenous nerve in these patients, I was able to get chronic pain relief for maybe 3 to 4 months with just one injection on the saphenous nerve superior to the knee. So I integrated this into my pain practice. This is before the age of the genicular nerve blocks, the radiofrequency lesioning of the genicular nerves, the peripheral nerve stimulators, before the PRP, bone marrow aspirate, all these other things I'm doing now. So the saphenous nerve is distal femoral nerve. Its branches distribution right down to the anterior thigh, emerges from beneath the sartorius muscle in the medial distal upper leg and continues subcutaneously past the knee joint, gives off the infrapatellar branch, and then continues distally, splitting off the medial cutaneous nerves of the leg. It follows the path of the greater saphenous vein and is almost unique for its size by being purely sensory in nature. The only other larger sensory nerve like this is the superficial cervical plexus. You start above the knee on the anterior medial aspect of the lower leg, thigh, and then you traverse the long axis of the leg, use a lot of gel, and you can move up and down or side to side looking for the nerves. They're typically next to the blood vessels. Okay, here's the femoral artery, the nerve is next to it. Sartorius muscle, the nerve is deep to it. Vastus medialis, the nerve is adjacent to it. Vastus medialis, not lateral. So the nerve will follow the greater saphenous vein, and you would typically start scanning here more or less. You could also find the nerve in the adductor canal, and it's next to the femoral artery, below sartorius muscle. It could be anywhere from 2 to 4 centimeters deep, depending on the size of the patient, of course. Here's just an image of the needle next to the nerve and some local anesthetic spread. The sacral plexus. The sacrum originates from L4 to S3 and is located, the sacral plexus originates from L4 to S3. It's located lateral to the sacrum. It gives rise to 5 distal nerves, the superior gluteal nerve and inferior gluteal nerve, the pudendal nerve, the posterior femoral nerve, and the sciatic nerve. The sciatic nerve is from L4 to S3, and the sciatic nerve is from the plexus, which comes from L4 to S3. The sciatic nerve is typically L5, S1, maybe L4, passes through the greater sciatic foramen between the two planes. The anterior muscle plane is formed by the obturator internus and the inferior gemellus muscles. The posterior, more superficial plane is by the gluteus maximus muscles. So here's an image of the sciatic nerve. The needle is coming in through the gluteal muscles, and there's local anesthetic spreading around the nerve. It's the black. Okay, it could be very easy or very difficult to identify the sciatic nerve. It all depends on you, your patient, and what type of probe you're using and how you're looking at it. With practice, it becomes much easier, of course. Once again, sciatic nerve, needle, gluteal muscles. You can use a curved 5 to 7 megahertz, which is a low frequency transducer, to see deeper better. I don't use that. I use a high frequency, and I've been doing pretty well with that. You want the patients to be positioned either semi-prone, usually in the decubitus position with the side that you're blocking flexed at the hip and knee, the knee brought up to the chest, as in this picture above. I would even flex it more than she's doing here, but and you're imaging the gluteal region. You could scan lower down in the subgluteal region if you can't find what you're looking for. The bony landmarks are the greater trochanter and the femur laterally, the ischial tuberosity medially. So back before the ultrasound, we were doing the ischial tuberosity to the greater trochanter, making a line, and then bisecting that line perpendicularly, a little distal, 3 centimeters. That was your starting point, right where that probe is, basically. It's about 1 to 2 centimeters in width. It can be even more in some patients. At times, it's less than 3 centimeters below the surface of the skin. It's hyperechoic, elliptical, deep to the gluteus maximus muscle, lateral to the biceps femoris muscle. And it's usually defined by, there's usually a well-defined border. That's the aponeurosis of the surrounding muscles. Okay, once again, greater trochanter, ischial tuberosity are the boundaries, lateral and medial respectively, and identify the plane at the depth. It's a you can look subgluteally if you can't find it there. So transgluteal sciatic nerve block, we're using that for lower extremities. And there's plenty of evidence that this has been helpful even for just sciatica injections, not even for surgery. So I do this sometimes for sciatica if I can't give an epidural because they're on a blood thinner or something, or with the pain that's coming from the buttock more than the back, whether it's a piriformis or even from a pinched nerve root in the back by a disc, it can give symptomatic relief. So you might want to try it with less gain. It can help a little more because it's a tricky nerve to find. You want to optimize your chance of success. Always survey in the same pattern. Find the trochanter, the ischial tuberosity, then search between them because that's the depth of your nerve, more or less. You could use a lower frequency probe if you're having difficulty visualizing down there. You also can do the focus points, which are points on the sides of some ultrasound machines that could give you higher focus at certain depths. I recommend no more than 2 focus points to be visible, and you can play with the level as needed, depending on the depth of the tissue you're trying to anesthetize. Okay, so here's how I position the patient on their side. The bone here is the ischial tuberosity. Here's a sciatic nerve leaving the iliac near the greater the foramen, more or less. You want to make sure you're scanning at the right depth. If you're having problems seeing it, have the patient flex their hip more. Okay, here's the nerve. Okay, here it looks actually triangular in shape. You go with start again, go to default settings on your ultrasound machine. This could be a tricky one. That's why I'm spending more time on the actual machine settings for this. Okay, first ID the greater trochanter, which is this bone right here. You're looking from the side. Then slide your probe all the way down to the sit bone, which is the ischial tuberosity. Okay, they look very similar. It's just a bone. It's a hyperlucent bone. Scan between them, or place your finger between them, and you'll feel a soft tissue area. That is where the sciatic nerve is. Now, this injected is for my pain office. I want my patients walking and leaving the office when I do a sciatic nerve block. So I'm diluting my local with saline, giving a little dexamethasone or depomedrol. I'm not giving more than 0.125% bupivacaine. I drive them nuts telling them that they're going to fall on the way out. They never do. I've had a lot of good luck with this, thank God. For you guys, you're anesthesiologists, you don't care about that. You're going to give 0.5% bupivacaine, 1/4% bupivacaine, anywhere from 10 to 30 mLs, depending on what you're doing. Ropivacaine is also great, of course, 0.2% or 0.5%, or the liposomal bupivacaine, depending on what your goals are. Just remember, you don't want the patient to be weak unless you know they're not going to walk, or unless you intentionally don't want them to walk for a certain period of time. It all depends on what you're doing this for. Right? If it's a amputation, you may want to consider using something longer acting, because you know they're not going to be walking on that leg or what's left of it. So here is the nerve, deep to the gluteal muscles. The piriformis is overlying it, and here's a local spreading around the sciatic nerve in that plane. Now, there are talks by some anesthesiologists of doing intraneural injections, which I think has fallen out of favor. I'm not up on the latest research with that, but just speaking from experience, if you if you accidentally get your needle too close to the sciatic nerve, the patient will get a paresthesia down the leg, but I've never seen any nerve damage from this. Okay, sciatic nerve continues down to the popliteal fossa, otherwise known as a popliteal nerve block. It splits 8 to 10 centimeters above the popliteal space. The medial portion of the lower leg receives innervation from the femoral nerve via the saphenous nerve, and this can extend around the leg, around to the midline and the posterior aspect of the leg. And for the medial aspect of the leg, consider a saphenous nerve block. So the popliteal sciatic block would be indicated for any sort of surgery of the lower leg, excluding the medial aspect. You have peripheral stimulation. That's what we do in the office, peripheral nerve stimulation. I just did a case on Friday for a patient with post-stroke pain. He had chronic foot pain from it, so we did a nerve block first, did better. So I put a wire there with an external battery for a permanent implant. You can help patients who have neuralgia also, or you could do this in the OR for patients undergoing any sort of foot surgery, debridement, amputation, etc. So the 7 megahertz probe or higher, I like the high frequency probe for this. You look in the popliteal fossa, you scan up and down, you find where the sciatic nerve divides the peroneal nerve and the tibial nerve. Sciatic nerve is often round and hyperechoic. It's located posterior to the femur, loud to the popliteal artery, and deep or anterior to the semitendinosus and semimembranosus muscles, and the biceps femoris muscle as laterally. More distally, the peroneal nerve may be followed far laterally as far as the head of the fibula. Remember, anesthesiologists, this is a board question, right? Peroneal nerve entrapment, foot drop after lithotomy surgery that's going on for a long time would be the peroneal nerve entrapment at the fibular head. They ask this on the boards all the time. Okay, here's the bifurcation, what it looks like. The nerves separate. The tibial nerve is classically larger and more medial, the peroneal nerve smaller and lateral. Here I'm scanning downwards and my movie is not playing. Give me a second. Let me figure out what happened here. So let's make sure the share is optimized for video. Sorry about that. And it is. Let's see why it didn't work. Okay, there we go. Here's a nerve. It's going to bifurcate. Watch. And there we go. Okay. Tibial nerve over here. Peroneal nerve more laterally. One more time. Here it gets more superficial as you go down. And here they just bifurcated. Okay. When you don't know where you are, you can always scan behind the crease of the knee and you'll see the nerves very superficial. Okay, this is what they look like. And then scan upwards, or you can start up top and scan downwards as the sciatic nerve bifurcates, depending on what's easier for you guys. Okay, popliteal nerve block precautions, the local anesthetic, it's hypoechoic, it's black, okay? Takes a longer time for the onset. So surgeon may start, patient feels something or moves and he starts screaming. Well, he's not supposed to scream these days. We're supposed to all respect each other, but you know what I mean. You might need to prep him or use a local anesthetic with a quicker onset. It really depends on your situation, but just remind the patient that they'll be numb for a bit after this. It's a longer duration as well as longer onset. And of course, fall precautions. When I do this block in my office, even though I'm using very dilute local and limited volumes, I'm telling the patient, you may walk out of here well in 30 minutes and not feel weak, but you could in an hour be weak or have no sensation and be at a big fall risk. So I don't let them leave on their own. Okay, this is a nerve block that traditionally has been used for pain docs in the outpatient. However, with more surgeries becoming ambulatory and with the maybe cryotherapy devices or the peripheral stimulation devices that regional anesthesiologists may be implementing in practice in coming years to facilitate same-day surgery, early discharge, adequate opiate-sparing pain relief. You should learn about the genicular nerves. It's not just a chronic pain thing. My partner, Gary Schwartz, has done genicular nerve blocks for knee replacements in addition to the IPAC and maybe the femoral or the adductor canal block. And he's enabled patients to go home the same day as a knee replacement, enable them to move their knee the same day. So we've come a long way from just a femoral nerve block and a spinal for knee replacements. So just a little background, the genicular nerve block, I'm not really sure where it comes from, the genicular nerve, because I found different sources from different places saying different things. The nerves in some sources are tibial and common peroneal, tibial giving the superior and inferior medial genicular nerves, but then I find in other literature that they arise from the vastus medialis, which is a branch from the femoral nerve. So we're getting all these conflicting reports. You know, at the end of the day, either way, you just got to block them and take care of the patient. So I'm not going to get too crazy with all this. There's the middle genicular nerve, which is a branch of the nervus intermedius, giving sensory to the superior and anterior aspect of the knee joint capsule. The lateral retinacular nerve supplies the lateral aspect of the knee joint. The inferior medial genicular nerve is from, here they're saying it's from the infrapatellar branch of the saphenous nerve. Either way, these nerves run close to the artery. The lateral inferior genicular nerve is not typically targeted, especially for a lesioning, because you get a foot drop. It's very close to the peroneal nerve. So here's how the nerves run. Okay, whether you believe it comes from tibial or sciatic, sciatic or femoral sources, the bottom line is nerves pass like this. Superior medial will pass over the epicondyle anterior to the knee. The inferior medial runs right under the knee and goes more medial and superior towards the joint. And the lateral one is at the epicondyle over here. Lateral views, you see the nerves coming and they run with the blood vessel and they run from the lateral wraparound anterior in towards the joint. So with an X-ray guidance, these were the techniques we would choose. I won't spend much time on this since you guys are not doing it. Even though for knee cases, you guys do have an X-ray in the room oftentimes. So theoretically, you could do an X-ray guided shot if your surgeon was flexible. But if you have an ultrasound, why not just use the ultrasound? So this typical pain doctor's targets of the nerves would be like this. That's the classic approach. The newer approach is actually where the diamonds are. The nerves are more superficial. There's less skin between the bone at the corner of the epicondyle as opposed to the junction between the shaft and the epicondyle. It's a little deeper of an injection, and more painful, but you'll get better relief. And this is where we target our lesioning when we do radiofrequency lesioning. Under ultrasound, you have a cross section here of the superior medial genicular nerve. Okay, you're scanning in I'd say a coronal section above the epicondyle, and you're finding the pulsation of the artery with Doppler, and the nerve is the whitish hyperdense tissue next to it. It may appear as an oval, a line. Usually is very amorphous, doesn't have a specific shape. It's just small and next to the artery. These are tortuous vessels and nerves, so they're not going to have the same appearance in every patient. For instance, here you go. Okay. So here you're getting a section of the artery as it wraps around. This hyperlucency is probably the nerve. Once again, you change the orientation of the probe. Here's the nerve. Here's a transverse view of the superior lateral genicular nerve. Okay, pulsatile flow next to hyperlucency is probably the nerve. Here's a video of me doing the block in the office, which is applicable somewhat to you guys, so I'm going to play it. We're going to do a genicular nerve block. There are 3 branches, the superior medial, superior lateral, and inferior medial branch. Looking for the superior medial genicular nerve, I scan the medial side of the knee, putting on color Doppler, running along with the artery, close to the epicondyle. Take off the Doppler, and one can see the nerve next to the artery. Scanning distally, the nerve approaches the corner of the epicondyle with the blood vessel. As it descends to innervate the knee. Low pinch, okay. Causing 1 to 2 mLs around the genicular nerve. Amplopivacine 0.25%. Now we're going to target the inferior branch of the medial genicular nerve, going below the knee joint onto the tibia, the medial aspect, looking for the blood vessel. It's a small nerve here. May be difficult to find at times. And it runs with a blood vessel and superficial to the bone. It appears that the nerve is right here. Take off my Doppler. Go pinch. Injecting another 1 to 2 mLs around the genicular nerve in the inferior medial position. The bone over here is the tibia. Now we're going to scan for the lateral branch, which also runs with a blood vessel. So I'm going to put my Doppler on as I scan for the blood vessel to help me isolate the nerve. And I like to go as distal as possible on the epicondyle
and I'm scanning proximal to distal. I'm looking for the nerve in the blood vessel. Too much pressure in the blood vessel will disappear, so it's important not to press too hard. But I found the artery, and the nerve is right under it. There we go. There's a picture of it. And on top of the artery, and I'm going to get the needle slightly lower. Anesthetize the nerve underneath it. There we go. That's it. That's the nerve right above my needle. The arteries to the left of it. Much easier to see after the local anesthetic has been given.
Okay. So if there's any questions, feel free to ask. Here are some of the references. Okay, the IPAC is also a very useful block. Infiltration between the popliteal artery and capsule of the knee. I do this all the time in my pain office for posterior capsule pain. People who have pain in the back of the knee that's not relieved with a joint injection or even a saphenous or genicular nerve block, or maybe they have a Baker's cyst. It works really well, and it doesn't really give much motor problems, so they can walk right out of the office. Here's a needle. Here's a tibial nerve and the back of the knee capsule. Okay, this is how I do it in terms of, here's the position. Here's how I put my probe. Here I'm injecting steroid. That's why the needle looks white. The syringe looks white. But it's the same idea in the operating room. If you were going to do this for, let's say, a knee replacement or something, you could use a liposomal bupivacaine and bupivacaine mixture for this. Okay, it's a pretty low risk procedure. Okay, scanning the foot. Most of the time, you guys get away with an ankle block, mainly a cuff of anesthesia around the ankle. But if you want to be really precise, here's what I recommend. You could actually scan each of the ankle block nerves and inject them, lower volume with a little more finesse. Here's a saphenous nerve. So we're looking at the medial malleolus, a little anterior to that, the saphenous veins right here, and it's collapsible, and the nerve is right next to it. The sural nerve is posterior lateral, and it does innervate the lateral aspect of the foot. The saphenous is the medial side, right, the instep. Here's an angle for the sural nerve. So it's right by the Achilles tendon and soleus muscle. Flexor hallucis longus is over here, peroneus brevis. It's a little confusing looking at this with the anatomy. You kind of need to practice scanning it, look at the anatomy books, and then you get the idea as to what you're looking at with the view. So here you have the Achilles tendon, then you have the small saphenous vein next to the nerve. And the soleus muscle is not really well shown here, but tibial nerve. Okay, you could scan upwards for the tibial nerve. And you see the tissue changes, but the nerve is next to the artery. right over here. There it is right there, in between the muscles. Okay, I've done nerve blocks here for foot issues or for peripheral neuromodulation. You just might need to supplement. This is going towards the medial aspect of the foot and getting underneath the foot. There's your flexor digitorum longus muscle, flexor hallucis longus. If this isn't making sense to you, don't worry. Once again, you need to just scan it and look at the anatomy books on your own. That's why I encourage you guys to come to the courses. I'm giving a course April 18th. I hope to see you guys there. Here's a nerve. There's information about the course on the PainExam website, painexam.com. Go to the events page. The deep peroneal nerve at the dorsal aspect of the foot at the ankle here. Here's the anterior tibial artery. Here's the nerve. Very small and flat, the nerve. Superficial peroneal nerves, more superficial. It's right there. It's flat. I'm scanning downwards on the top of the ankle. Tarsal tunnel syndrome, it's more of a chronic pain issue, but just so you understand, the tibial nerve can get impinged is like a carpal tunnel of the foot, more or less. You have the medial plantar nerve, the lateral plantar nerve, and the calcaneal branch. Okay, so tibial nerve is a big deal. So if you have any surgeries of the bottom of the foot or pain there, tibial nerve is a major play here. Of course, you'll get them all if you do a sciatic nerve block, and probably that might be what you need to do. But let's say you need to supplement and you don't want to give a large dose of local because maybe they received 30, 40 mLs of local and maybe you missed. You don't want to predispose them to having any toxic reactions. Well, to give 2 or 3 mLs or 1 or 2 mLs of local right on the tibial nerve can save the day. Okay, this is just where the impingement would occur of the tibial nerve at the tarsal tunnel. I'm not going to spend much time on treating it. Here's another image of the tibial nerve at the tarsal tunnel. Here's where you put your ultrasound probe. And the references. Okay, so next unit will be peripheral nerve blocks. We'll take a break. Let's come back at about 12:30 or so. Let's do 12:30, okay? I'll see you guys soon. Any questions before we break? Okay, great. I'll see you guys soon. Okay, welcome back. Took a little longer than usual break just now because I want to hopefully finish early and try to minimize the breaks from here on. We have 3 more units to get through: the peripheral nerve blocks, the fascial plane blocks, the ones I didn't cover already, and the spine. So I'm going to try to go through it. It's a weekend and it's also daylight savings time, so some of you may be tired or itching to do other things. It's the weather is, I guess, sort of decent for this time of year. So let's get started. If there's any questions before we begin, just shoot me a text through the chat or the question area, and I'll pause and answer them. So the general femoral nerve block, a lot of you may not be doing this for surgeries. However, it may be something more relevant with the possible future peripheral stimulators or even the longer acting local anesthetics. And the general femoral nerve, here I'm talking more about the genital branch, but the nerve arises from the lumbar plexus. It has the sensation to the skin of the anterior scrotal area in males, the mons pubis in females, and the upper segments of the anterior thigh in both males and females. While distinct from the femoral nerve, the genitofemoral nerve originates from the upper lumbar L1 through L2 segments. It runs with the ductus deferens, spermatic cord, testicular artery. It can be hard to distinguish. It descends inferiorly, piercing the psoas major muscle before it emerges on the anterior surface. The nerve then traverses the retroperitoneum, descending over the anterior surface of the psoas muscle. So here's the nerve right there. Here's the testicular artery. And I'd say spermatic cord is in this region. Ductus deferens as well as right there. The nerve continues inferiorly, ultimately separating into the 2 divisions, the femoral and genital branch. The genital branch is what we're looking at here. And it reaches the deep inguinal ring coursing through the inguinal canal. Here's a nerve block being performed, and I'm infiltrating. You have to be careful not to get into the spermatic cord. The nerve is in this area. It's a little hard to see which of these hyperlucent structures is the nerve. On the previous image, it was a little clearer. But if you get into that region, you're probably going to get good coverage. Neuralgia paresthetica, another very popular board question for anesthesia boards. Myeloneuropathy of the lateral femoral cutaneous nerve. It can be a real problem when it's not properly diagnosed. Patients can be treated for all sorts of disorders: hip pain, bursitis, lumbar radiculopathy, and the patient could still be complaining. I mean, in a worst case scenario, a patient could actually go for surgery of the back when it's not even radicular. The pain is typically burning, coldness, lightning-like, deep muscle aching, tingling, or frank anesthesia with hair loss in the anterolateral thigh and the distribution of lateral femoral cutaneous nerve. It's primarily a sensory nerve, but also has efferent sympathetic fibers carrying vasomotor, pilomotor, and sudomotor impulses. It's variable, but L2 and L3, L1 and L2, or L2 and alone, L2 alone or L3 alone can be responsible for the origin of this nerve. It's associated with femoral nerve as it passes through the inguinal ligament and may anastomose with the femoral nerve distal to the inguinal ligament. On occasion, the lateral femoral cutaneous nerve is absent and may be replaced by a branch of the ilioinguinal nerve. Frequently found passing through the split lateral attachment of the inguinal ligament, and the nerve can curve medially and inferiorly around the anterior superior iliac spine. It can be subjective to repetitive trauma in this fibroosseous tunnel. Once again, cutaneous innervation lateral thigh, usually dorsal branch of L2 and L3, passes under the inguinal ligament, 2 centimeters medial to ASIS, superficial to sartorius, and divides below the sartorius muscle into anterior and posterior branches. The nerve is superficial to the iliacus muscle between the fascia iliaca and fascia lata. So this is what we're talking about. This is a cross section. Here's the ASIS. Here's where the nerve is. This is the iliacus muscle. Here's sartorius. Here's iliacus. Okay, we're at we're a little bit below the inguinal ligament. Here's a nerve under sartorius. Okay, now moving on to our next lecture. If there's any questions, feel free to ask. Fascial plane blocks. Okay, just give this a second while it's loading. Okay. I do have the spine one open, so I'll start with the spine block, the spine presentation. This was originally my last presentation, so the ending slides are on this one, but it's okay. So I don't want to waste anyone's time. Okay, so this is a presentation that's been altered quite a bit. As you know, as a pain doctor, I have a lot more to talk about with spine, especially with ultrasound. But I'm trying to apply this to what's relevant to you guys, plus a few extras. I'm not going to stick strictly to pain because to anesthesia, because there is some content that could be valuable to you. But for the main point, it's an abbreviated talk due to the fact that this is more of an anesthesia webinar. So very important for your boards, if you're not even doing it in your practice, at least for your board exams, stellate ganglion block, used in the treatment of complex regional pain syndrome, type 1, type 2. Type 1 is like RSD, reflex sympathetic dystrophy. There's no known nerve injury. Type 2 is causalgia. So you have a known nerve injury. Stellate ganglion causes vasodilation, so it's been used in Raynaud's syndrome, accidental intra-arterial injections, acute herpes zoster of the face and lower cervical and upper thoracic dermatomes. It's actually been said to help with pulmonary embolism, which I've never performed a stellate ganglion block for pulmonary embolism. I don't think it's something that most people are doing. Well, I know it's not what people are doing, but I would imagine the reason is because of the vasodilation of the pulmonary vasculature. That's my guess. And maybe some of the sympathetic blunting can actually help with the supply to demand of the oxygen ratio in the heart. So the sympathetic nerves in the stellate ganglion, they are composed of the gray rami communicatings of C7, C8, and T1, occasionally C5 and C6. In some patients, T2 and T3 gray rami innervate the distal upper extremity and do not pass through the stellate ganglion. Hence, you could do a stellate ganglion block and not get adequate pain relief. You get the Horner syndrome and know that you're there, but still the patient may have sympathetically mediated pain that is not getting relieved because of you're missing the T2 and T3 gray rami communicating fibers. Other pain syndromes that are helped with a stellate ganglion are the phantom limb, refractory angina, vascular insufficiency, Raynaud's syndrome, scleroderma, frostbite, obliterative vascular disease. We mentioned vasospasm, edema, etc. So the complications of the stellate ganglion block, remember, you're in the neck. You have all sorts of blood vessels and nerves and structures you want to avoid. Blood vessels, of course, carotid, IJ, nerve injury, vagus nerve, brachial plexus roots, pulmonary injury, pneumothorax, hemothorax, chylothorax, esophageal perforation. If you get intravascular injection, carotid artery, vertebral artery, the IJ is mentioned, you get spread to the neuraxial structures, the cord, you shouldn't get it, but you're pretty close to the spine. So yes, you could. You could, of course, get a brachial plexus block. You may get recurrent laryngeal nerve paralysis, palsy. You could have hoarseness, elevated hemidiaphragm from phrenic nerve. That's one of the reasons why we don't do these bilateral, also for pneumothorax. And of course, infection could also be a risk. So here we have an image of a patient who had a stellate ganglion block and a Horner syndrome has developed, ptosis, meiosis, and hydrosis. When scanning her neck medially to the carotid artery, you see a huge blood vessel called the superior thyroid artery. So going medially, this is one of the challenges you have to get past. Put some Doppler on. Make sure it's truly a blood vessel. There's also a big structure called the esophagus, which I'm sure many of you are familiar with, which you do not want to perforate. And back in the day, the pain docs or the anesthesiologists would just do these blind. You take the patient's carotid pulse, pull the carotid to the side, get between the trachea and the pulsations of the carotid artery, inject till you encounter bone, withdraw a few millimeters, aspirate, inject. You can imagine that that's probably not the best way to do it, especially when on the left side you have this esophagus. Watch it right here. There you go. Okay, I think this is my neck, so I just swallowed and air, and that's what gave that image. Look again right here. There you go. Okay, so you don't want to perforate the esophagus, obviously. So ultrasound has really made things a lot clearer. When you look through the ultrasound, you could scan above and below the thyroid arteries, as I did here. I've got a nice homogeneous picture of the thyroid gland. And this is an ideal spot to go with my needle to get to the stellate ganglion, which is posterior to the carotid artery, anterior to the longus colli muscle, which is a little hard to see here, lateral to the esophagus, and more anterior to the esophagus. You can do a lateral approach as well, in which you come in from the side, but you need to be careful with the brachial plexus. It may be easier to do this on some patients, may not be. Here's a lateral approach. That's the C6 transverse process. The medial approach, as I showed you earlier, you come in like this. This is a straight shot down here. And if you're very good with the needle and very careful, it may be easier and some patients may not be. I typically have the patient lie back, tilt their head of the table up a little bit so the medication can go downwards, because we're working at C6 or so, but the ganglion is lower down, C7, T1. And I would also have the patient lift their neck up a little bit to create some space to work. Here's a video of this. Okay, so see the thyroid blood vessels right here. Injecting 25 gauge, 1.5 inch needles, all I need for this patient. And you gotta be very careful not to mess with that carotid, okay? Right posterior of the carotid. I'm also using this for PTSD. It's helping. Giving some local anesthetic on the stellate ganglion on the right side is helping with the sympathetic symptoms of PTSD, post-traumatic stress disorder. Okay. Usually injecting just some local. You don't even need steroid. The contraindications: anticoagulant therapy, pneumothorax, pneumonectomy, recent cardiac infarction because the stellate ganglion cuts off the cardiac accelerator fibers, so you don't want to precipitate a bradycardia. Glaucoma is a relative contraindication because of provocation of glaucoma with repeated blocks has been reported. Caution with patients who have AV blocks or impairment of cardiac function. Complications: pneumothorax, neuraxial injection, phrenic and brachial plexus block, cervical nerve root, puncture block, vocal cord paralysis, vascular puncture, hematoma, esophageal perforation. Okay, the sacroiliac joint. As an anesthesiologist, you may get asked to do a pain consult on the floors. And if you don't have a C-arm or skills with an X-ray machine, you want to evaluate the lower back pain. The sacroiliac joint presents typically as buttock pain radiating down the leg, not exactly like a sciatic nerve or sciatica, but very similar. There may be some numbness or pins and needles, but usually not. It's often a pain. Very rarely are there any nerve deficits, so there shouldn't be any weakness. There should be sensation, should be intact. So the bones overlap each other here, and you can see the iliac bone and the sacrum here, and you're just coming with your needle and you're going to inject a little steroid, maybe 20 to 40 milligrams of depemedrol and 0.25% bupivacaine. And this is something that might help the patients and help get them out of the hospital if they're there for pain. Okay, facet injections, similarly, you can do a bedside facet injection. The insurance companies are considering these experimental procedures. They've been experimental for the last 10 to 12 years. I've done plenty of them, so I know they work. You might not be able to judge the level you're at so easily with an ultrasound, but it's doable. Here's the facet joint opening. Once again, the needle, facet joint, this is the spinous process, this is the lamina. It's possible to see the epidural space under ultrasound. I do not have a slide of that here because I don't use it. If I'm doing the epidurals, either with X-ray or an ultrasound caudal, which I'll show you, or just blind. Here's a cervical vertebral body. This is the anatomy and the shape of the vertebral body. This is how they're shaped. You scan, once again, the brachial plexus. First, look at the thyroid, the carotid to get your landmarks for the interscalene brachial plexus. This is the same movie as before with a little extra focus on the axillary nerve root. So here's the interscalene brachial plexus. As you slide north, these nerves come into the spine. They go into the foramen, which is located right about here. Okay. And watch that nerve just go back. It's not a blood vessel. It looks like a blood vessel, but if you put Doppler on, it's a nerve. Here's your carotid. Here's your vertebral arteries. Okay, just to give you some appreciation of where we are. This is the posterior, the articular process right here. Okay, the posterior tubercle is somewhere here, anterior tubercle is over here. That might be chaster nags right here. See how it's coming out like this? This is anterior, this is posterior. Here's lateral. You're coming in from laterally. Ultrasound is resting laterally on the side of the patient's neck. Okay, you as an anesthesiologist will not be doing much selective nerve root blocks of the cervical spine. In fact, most pain doctors aren't doing much of these. I just wanted you to get an idea as to what it looks like in case, let's say you did need to do some sort of block or they had some surgery. You never know. The more you know, the better off you are. So that's the nerve. Here's the articular process. Here's my needle coming in. I use a 25 gauge, 1.5 inch needle over here. And I just give a little bit of bupivacaine mixed with dexamethasone to anesthetize the region. Okay, this is where it's correlating to. Around here is right about here. That's the nerve. Cervical medial branches, these are the nerves that innervate the soft tissue and the joints in the neck. Okay, we do radio frequency of these. I recently placed a peripheral nerve stimulator under ultrasound in this region for a patient who's extremely happy. See, each facet joint is innervated by 2 nerves. This is on your anesthesia boards. It's not just pain stuff. So before you dismiss it, it's very important. Okay, the axillary nerve root, the medial branch comes off of it and goes up to the facet joint at that level and the one below. Here's a cervical medial branch nerve when looking from the side of the neck. Okay, the nerve comes around here, loops around to get the joint as well as some of the soft tissue. When you go oblique and longitudinal with your probe, this is what the nerve looks like along the cervical articular processes. The caudal, this is useful, okay? I remember I was doing years ago some sort of, I don't know if it was a hip surgery and the spine was wearing off and the patient was in the laryngeal position, sedated somewhat with a propofol. And, us pain doctors, a lot of us will do epidurals under sedation. So what's the difference, I guess, right? So I remember going in and placing an epidural intraoperatively while they were working on the patient's lower extremity because the spinal wore off, and I was able to put a catheter and bolus the catheter for perioperative and postoperative pain. In certain situations, let's say you can't get the epidural, or it's very old-fashioned to do a caudal on an adult. I think it's more common with pediatrics. Same concepts either way. Let's say you want to get neuraxial analgesia, you don't want to do a spinal, or for some reason, or maybe you want to bottom out the pressure, you want to go low and slow, get a nice, slow, gradual level of local on, and for some reason you can't get to the epidural space. With an ultrasound, the caudal space is very accessible. It's very easy to find. You can place a catheter here. You need to, of course, give more local to fill it up because it's just a larger reservoir of space that you have to fill up. But even if there's a pelvic surgery, you might be able to do some good work with this. Or a lower extremity surgery. It really depends on the volume you give. You're less likely to get a dural puncture headache. These are just some epidural doses if you're running infusion. Starting doses, I mean, it really varies depending on what you're doing. Thoracic needs less volume per hour to start with. You may not get a motor block. We used to use Dilaudid at NYU. I haven't used Dilaudid in years, usually for thoracic cases because it would spread really well in the epidural space and get the dermatomes. So here we go, caudal. Okay, that's the sacral hiatus right there that we just saw. So we're looking at a cross-section of the cornu of the sacrum. It's the frog sign. Those are like frog's eyes. The hyperlucency between them is the sacrum, the bottom of the caudal canal, and the coccygeal ligament is that soft tissue above it. Turn the probe 90 degrees and you go sagittal and parasagittal. Sagittal, you don't see any cornu, but if you go parasagittal, paramidline, or paramedian, you will see the cornu. That's the cornu right there. It's only one cornu because you're in the sagittal plane. That's why you don't see both. I'm giving local anesthetic to the soft tissue, trying to get the cornu out of the way to be midline. And here's my needle coming in. And as you see, my angle is not the best angle. It looks good now, but I'm going to bump into the top of the canal and redirect. For some reason, I'm too high. So I'm just pulling back. And I'm taking a different approach, different trajectory to perforate the sacrococcygeal ligament and get into the caudal space, which I just did. Inject here and you'll see some spread a little retrocaudally, which you see under fluoroscopy as well. And that's it, really. That's all there is to it. There is a loss of resistance similar to an epidural. You could do this in the peds patient. You could do this in the adult. Okay, lumbar sympathetic plexus, superior hypogastric plexus, ganglion arm parvoc. Not so relevant for anesthesiologists in general, but they're relevant for your boards. Here's the S1 foramen. If you're trying to be slick and you want to get into the epidural space, you could try getting through there. I'm not really sure what situation you would really have for doing this. I never did this as an anesthesiologist. As a pain doctor, I've done this under ultrasound for a patient who I couldn't get to the C-arm suite. And what I can tell you is I gave maybe 2 mLs, 0.25% here, and it spread across the midline. And he got bilateral lower extremity temporary weakness. In the office, I had to watch him for a bit. So go figure. The guy had a very acute radiculopathy and was crying on the floor. So at least he felt better. But he had to wait for a couple hours until he started to get some more. He wasn't completely weak. It was only 2 or 3 mLs, 0.25%. So he had some weakness, but he was able to bear some weight. He didn't have to spend 6 hours in the office, nothing like that. Now, this is something you probably don't know about, or you might. It's a big target for peripheral neuromodulation these days. These are cluneal nerves, and I'm kind of bringing this up because these are superficial nerves that can be anesthetized for certain procedures, such as, let's say, a IPG for a spinal cord stimulator implantation. That's the implantable pulse generator, which is like the battery of the spinal cord stimulator. If you anesthetize these nerves, patients may get relief there. These nerves were ignored for years. We knew about them for a long time. In fact, I remember them from med school, but I didn't realize the significance of them until recently. These nerves innervate the gluteal muscles and basically the soft tissue of the buttocks. And you have the superior medial cuneials, the middle cuneial nerves, the inferior cuneial nerves. When I was in training and I'd see patients and they'd have pain in this region, and we call it a trigger point, and we'd give them all trigger points. When I wrote my pain exam review, there was nothing in any of my references talking about the cuneial nerves. I read the textbooks from front to back, and I wrote my review off these textbooks like Benzin or Raj. I don't remember any of this. And then what happened was I started doing neuromodulation, and one of the reps like, well, why don't you just do the cluneals? And I'm like, oh, cluneals. So I started to learn more about it. In fact, I wrote, it's not published yet, but I wrote a couple chapters in an upcoming peripheral neuromodulation book by Andrea Trescott. And I realized a lot of these patients with trigger points along the iliac crest, especially at the PSIS, right by that ball, they call it. The patients always say, I have a ball in my back, and they can palpate this point. And a little bit lateral, you can even palpate on yourself. There's a tender spot. You know, when it comes to finding nerves, you don't always need an ultrasound. You can sometimes ask the patient or yourself, where do you feel the nerve is? Where's the tender spot? For instance, I could just touch my median nerve right here, and without an ultrasound, I know this is my median nerve. It's the tender point. Okay, so when you do that along your own iliac crest or the PSIS, you could palpate these nerves and the points where they are. There's usually 2 or 3 of them at different points here, and the patients will come in with these points, and 99% of the doctors out there will say, oh, you have a trigger point. It's not necessarily a trigger point. It's more of a nerve irritation or entrapment. There's a fibroosseous tunnel at the thoracolumbar fascia at these levels. And instead of giving a trigger point, which is basically a local anesthetic injection in a fan-like distribution, I'm giving an ultrasound-guided pinpoint nerve block, getting better relief. And then we're able to make it last longer with either repeat injections, steroid injections, radiofrequency ablation, cryotherapy, or peripheral neuromodulation with electricity. And these patients come in with low back pain involving the iliac crest of buttocks. There's numbness radiating to the distribution of the nerves. And you may get a patient who's going for a surgery, maybe they're excising some mass or something in the soft tissue, a cyst, and you can maybe do this nerve block for postoperative pain. That's why I'm bringing this up. Okay, these are the common points. It's often dismissed as SI joint pain, gluteal trigger point, facet joint pain.
The superior cluneal nerves originate from the dorsal rami of primarily the upper lumbar spinal nerves. The nerves cross the iliac spine to innervate the skin and subcutaneous tissue over the gluteal region. The nerves extend as far as the grea trochanter, and the area of innervation may overlap anterolaterally and the iliohypogastric and lateral femoral cutaneous nerves. A reliable nerve block technique may have the application in the management of postoperative hip pain surgery as well as other clinical conditions, for example, chronic low back pain. This superior cluneal nerve block will anesthetize the skin posterior to the area innervated by the iliohypogastric and subcostal nerves, improving anesthetic coverage for hip surgery. A diagnosis of superior cluneal nerve and medial cluneal nerve entrapment may be made by palpation of the iliac crest or long posterior sacroiliac ligament, resulting in marked tenderness and provocation of symptoms, and pain relief with local anesthetic injection. The superior cluneal nerve tender point on the posterior iliac crest is approximately 70 millimeters from the midline and 45 millimeters from the posterior superior iliac spine. And the osteocomponent of this tunnel is the rim iliac crest, and the fibrous component is the tough thoracolumbar fascia. Now that's the medial branch of the superior cluneal nerve. Now, this is a patient who originally had a sacroiliac joint injection, as well as gluteal trigger points, gluteal bursa injection without any long-term relief. And on exam, she did have a positive Tinel's near the iliac crest, right where my needle is and where I'm working. And what I did first is a longitudinal view, and I identified and anesthetized a medial branch of the cluneal nerve. And now I'm doing a cross-sectional view with a transverse approach. And the nerve is quite small and difficult to identify. And the best way to identify a positive nerve block is to have the patient report response with only 1 or 2 mLs of lidocaine 2%. This patient did very well and is going to go on to peripheral neuromodulation. This patient had a laminectomy and axial pain to the right side, radiating to the buttock and hip. He was unwilling to come for a fluoroscopic facet or medial branch nerve block, and in the office I performed a superior cluneal nerve block at the higher lumbar regions where his trigger points were, that were radiating down to the lower back, buttocks, and side of his hip. Upon going towards the more superficial hyperlucency, the patient reported concordant pain. Upon redirecting the needle and depositing 1 ml of lidocaine 2% at the deeper trigger point or hyperlucent spot, the patient reported pain that correlated exactly with the superior cluneal nerve distribution. It radiated from this region down to his buttock and side of his hip. The patient reported immediate pain relief and is to be followed up in the office for possible repeat injection or maybe peripheral neuromodulation in the future.
Okay, here's just another video to kind of show you. Some patients may have hardware implanted. This is a spinal cord stimulator. So here's a cross section of the lead. This is where it is and the shadow behind it. So we're just scanning up and down to find the cluneal nerve where I'm putting the needle. This is a patient who failed back surgery, more of a chronic pain point. However, if you're doing these nerve blocks on people, you may find areas where they have hardware and need to work around the hardware, as I did in this case. So that's the hardware right here, and then my needle's just passing under it to get the cluneal nerve. And that's PSIS, the posterior superior iliac spine, and the nerve is right here. Medial nerves, they just run lateral from the sacral foramen. The posterior superior iliac spine and the sacrum, the posterior longitudinal SI joint ligament connects the two. And the nerves run through this ligament or near it, and they can get entrapped by it. So we would just block around that region. Okay, here's a parasagittal view of the sacrum. Here's the S1 foramen. Here's the facet joint, and this is a cross section of what I believe is a nerve. It's going to come up here soon. So that was the foramen, the gap in the bone. And here you go, foramen, and the nerve is coming right out of it. Let's go lateral. Okay, similar diagnostic criteria to trigger point or Tinel's sign. A little bit inferior to the posterior superior iliac spine, about 3.5 millimeters caudad. There's numbness, radiating pain in this region. It could be very often confused with sacroiliac joint pain. Inferior cluneal nerve is actually the posterior cutaneous femoral nerve, and the pain can radiate under the butt cheek, down the leg a little bit. The ganglion impar is a block you probably are not going to do, but if you're doing a surgery in the perineum, any work on the rectum, anus, genitalia, this could be very effective. If you could do this under ultrasound perioperatively, you can relieve a lot of pain for that patient. Let's say it's a patient you can't give a saddle block for, maybe for some reason you don't want to do a saddle block. There is a technique to do this with ultrasound. Most pain docs are not familiar with the ultrasound technique. In fact, I've only done it a couple times with ultrasound because of I have the x-ray. There's no need to use it. But if you get really slick with this, you might do a lot of good for the patient. So here's another video on that.
The ganglion impar is located anterior to the coccygeal bones. A blockade of the ganglion impar can treat perineal.
Hold on. Let's try that again. Sorry about that.
The ganglion impar is located anterior to the coccygeal bones. A blockade of the ganglion impar can treat perineal pain, coccygeal pain, rectal pain, and genital pain. The needle entry point is between the coccygeal bones through a ligament. Here we describe the out-of-plane technique with confirmation with fluoroscopy. You visualize in the longitudinal view the coccygeal ligament between the coccygeal bones, and the target is anterior to the coccyx and posterior to the rectum. Here you see an out-of-plane approach with tissue distortion from the needle tip. In this case, contrast is used to confirm with fluoroscopy. Here, the injectate spreads slightly laterally, but the center of the image is anesthetized with the injectate. By tilting the ultrasound, one can visualize the anterior coccyx clearly and visualize injectate spread. Injectate spread immediately anterior to the coccyx should avoid rectal spread. This can be confirmed with Doppler, under ultrasound, and of course contrast with the fluoroscopic approach.
Okay, so you'll see Doppler pulsations over here under the bones when you do this, and that's how you know you're in the right spot. If you go too deep, you could perforate the rectum, so don't do that. You're going to just feel right past you. When you're in the ligament, there's kind of a loss of resistance, so you cannot inject into the ligament. It's very difficult. So once you get past here, as soon as you're able to inject, I would aspirate, put in some Doppler, and inject. And if it looks good, you could give your local anesthetic. And you don't need to use a lot. And you could probably get a lot of pain relief for patients who have this sort of surgery. Okay, so a recap just would be, when you're doing the interscaling, you're getting the upper extremity from the shoulder down to the hand with the exception of the ulnar nerve. So basically shoulder surgeries are the way to go, maybe proximal humerus. Supraclavicular, the whole shoulder and arm with the exception of maybe you're not getting the suprascapular nerve, so you may need to supplement. Infraclavicular will be distal to the shoulder. Axillary distal to the shoulder. The femoral nerve block would be the anterior thigh, anterior and medial lower leg. You get the knee, at least part of it. And then the sciatic will be the posterior upper leg and the lower leg, excluding the medial aspect. Okay, so this is not the end of everything. Let me just go back to the other presentation, make sure the fascial plane block's loaded. In the meantime, if there's any questions, trying to tee this up. It's taking a while for some reason. This may take a couple minutes, so if you need to take a break, go ahead. I'll be here and I'll start when I'm ready. Another couple minutes. Almost there. Tell you what, why don't you guys take a break until about 1:20? I'll have this all ready for you. I'll just see you in a few minutes. I just want to make sure everything's set and ready to go. Thanks. Okay, we're gonna wrap it up with the last unit of the talk today and hopefully get out of here a lot earlier than expected. So this is the lecture on fascial plane blocks, which we've gone over some of them already in the talk. The quadratus lumborum block here is, well, the quadratus lumborum, it's a block that's wider than tap block, and the QL block blocks T6 through L1. The tap is T10 through, it starts at around T10, 12 and goes down to, excuse me, I shouldn't say that. The QL block includes those T6 through L1, and it involves the lateral cutaneous branches of the thoraco-abdominal nerves. Now, I just realized, so I stuttered, that my presentation got cut off for the peripheral nerve block, so we didn't get into those blocks. I'll try to go back to that. Okay. The QL block is indicated for exploratory laparotomies, large bowel resections, ileostomies, open laparoscopic appendectomies, cholecystectomies, C-sections, total abdominal hysterectomies. It's been used for open prostatectomy, renal transplant surgery and nephrectomies, abdominoplasties, and iliac crest surgery, bone grafts. The ventral rami of the spinal nerves, including the subcostal and iliohypogastric nerves, pass between the QL and its anterior fascia. If you look here, you see the muscle over here, deeper to the erector spinae muscles. The muscle's origin is the medial half of the iliac crest. Insertion is on the lower medial border of the 12th rib. There's 4 small tendon insertions to the apices of the transverse process of the upper 4 lumbar vertebra. The QL assists in lateral flexion of the spine. The patient is typically positioned lateral decubus position. The hip is abducted and laterally flexed, contracting the QL muscle. Scan mid-axillary line and move posterior to the tapering of the musculature, or scan 4 to 5 centimeters lateral to the lumbar spinous processes at L3, 4, or higher, usually going around the level of L4. So the probe is scanning here. And let me just, there we go. So we scanned more medial, and we see the tapering of the abdominal muscles. Here's the erector spinae, and QL should be coming up here. The picture froze a bit here because of sorry, just a technical difficulty with the presentation. Okay, here's an image of the quadratus lumborum. Here's the erector spinae. Here's the psoas muscles. So QL1 is basically going between the quadratus lumborum and the tapered abdominal muscles deep to the latissimus dorsi or the erector spinae. Okay, let me just redo the share. Hold on one second. This is a better version of the presentation, so everything should work better here. Let's try that one more time. Okay, we're scanning over. QL1 once again. QL2. Okay, so let me just see if I can get that downloading thing off your screen. Sorry about that. Okay. QL3, you're putting the medication between the quadratus lumborum and the psoas muscle. So once again, 1, 2, and 3. At the level of the L4 vertebral body, I don't have a good image of the shamrock sign here, but basically it's a level of L4. You're looking for the spinous process is the stem, then the psoas major, the erector spinae, and the QL are the three cloves of the shamrock. 1, 2, 3. Complications, thoracic spread as the thoracic and lumbar vertebral spaces are continuing dorsal to the diaphragm through the medial and lateral arcuate ligaments and aortic hiatus. Kidney injury. The lower pole lies anterior to the QL muscle, the right kidney lower than the left. The vascular injection can occur in any of the lumbar arteries from the aorta running to the psoas major muscle. The abdominal branches run laterally behind the QL and then move forward between the abdominal muscles. Peritoneum, bowel perforation, transient femoral nerve palsy can occur after QL. PEX and serratus block. The PEX nerve block was intended for analgesia after breast surgery. The PEX and the serratus plain nerve blocks for analgesia following thoracotomy and rib fracture. So this is a territory you're getting more or less T1 through T5. Many will use 10 mLs or so in the PEX major and minor plane, another 20 between PEX minor and serratus anterior. It's the position as if you're doing the infraclavicular brachial plexus block that you're starting at. PEX 1 between the two pectoral planes, between the PEC minor and major. PEC 2 between the PEC minor and serratus anterior at the fourth rib. You're getting the pectoral branches of thoracoacromial arteries. Lateral, you're seeing the pectoral branch of thoracoacromial artery, the lateral pectoral nerve, and the medial pectoral nerve. Sorry, it's been a long day. All right, so here you see the infraclavicular brachial plexus region. You see the PEC major, PEC minor, and your two targets, once again, it's under, it's between the two pectoral muscles around the second rib, and then you're going to go down towards the fourth rib between the pectoralis minor and serratus anterior. So PEX 1 block, you're getting the medial pectoral nerve and the lateral pectoral nerve. And this is the coverage. You're getting the tissue over here. And the medial cord comes from C8 to T1, penetrates the deep surface of the pectoralis minor to innervate the muscles before penetrating to its supply at the pectoralis major muscle. The lateral cord is from C567, excuse me. It penetrates the clavate pectoral fascia to supply the pectoralis major directly and through the communications of the medial pectoral nerve and the pectoralis minor. There's no cutaneous branch. This is for the lateral pectoral nerve. It can be located on the deep surface of the pectoralis major muscle. Here's where your probe would be. This is the orientation, okay? So you're changing the orientation from the infraclavicular block. PEX 1 block, medial to lateral, the needle is inserted, it enters between the plane of the two muscles, and it's between, and you could give about 10 mLs of local. Here it's between the third and fourth rib. You could first visualize it the second rib and start there. So some of the local went intramuscular. I recommend giving saline to dissect out the plane, just to make sure you're in the proper plane before you give your local. You don't want to be too much in the muscle and waste all your local here. You want to be in the plane. Here's another video of it. Okay. I prefer a little bit deeper to get in between the muscle planes and the layers. Right there. Okay, this is where you want to be. Okay, so PEX 2 block, you're getting between the pectoralis minor and the serratus. Here are the nerves. Ignore the top about the PEC minor and major muscles. That's wrong. The long thoracic nerve, C567, right here, at the anterior axillary line at the level of the fourth rib. So the probe is placed under the clavicle at the midclavicular line located, first locate the axillary artery and vein under the pec major and minor muscles, and then you're going to scan laterally. Okay. So here's the plane right here. Now you can move the probe more distally and laterally towards the axilla, and you could count the ribs. So you could count until you reach the third or fourth ribs. So we're going to scan ribs. Here's the second rib, third rib, and the fourth one's coming into view. And then you could identify the three muscle layers once you get this. Here's pec major, pec minor, and serratus. Okay, Flynn asked a question. For surgical and postoperative analgesia, which QL approach do you recommend? Well, I'll tell you, that's probably a better question for Gary Schwartz if he's still around. I don't know if he is, because I don't really do much of these days. But if I was faced with doing this, I probably would do both. Would do all of them. I'd dump a little bit on all sides just to get the best block possible. Gary, you want to add anything?
Yeah, I would just say that, you know, the QL1 is going to be closer to your tap muscle. So definitely you'll get a little bit of the spread into the tap. So that can be nice. And oftentimes going through the muscle towards the QL3, or rather the QL2, can also give you deeper spread so that you possibly hit more of the more of the deeper nerves. So I think all three, like David was saying, would be ideal if possible.
Thank you. Okay, PEX 2 block at the serratus anterior muscle and the PEX minor muscle. Between them, you can inject 2 mLs of local. And here is the rib. Here's the serratus. Here's my needle coming in. By the way, I'm doing a lot of these for chronic pain. I have patients who come in after breast surgery, reconstructions with a lot of chronic pain. So I've been doing these in my office and treating patients, and it's been helpful. So the serratus muscle is just above the ribs here, and I'm getting between them. If we saw 3 layers, it depends on where you are. It could be the pec major on top. If you're more in the axilla, what you'll see with the serratus block, it's really the latissimus dorsi muscle. And this is where I'm working over here, down here. Okay, so they compared the thoracic paravertebral blocks to the PEX block in 40 patients undergoing modified radical mastectomy. Both groups had received 25 mLs of ropivacaine 0.5% and morphine PCA. The PEX group had decreased 24-hour morphine requirements, lowered pain scores, and longer duration of analgesia. So it's a great block. It helps. Serratus anterior block, you have the latissimus dorsi and the serratus anterior muscles. The thoracodorsal artery runs in 2 fascial planes between the two. Targets the lateral cutaneous branches of T2 to T9, the intercostal nerves, which innervate the anterior lateral chest wall. Superficial to the serratus anterior muscle, between the serratus anterior and latissimus dorsi lies the thoracodorsal artery and the thoracodorsal nerve and long thoracic nerve. Okay, here are the 2 nerves right here. Here's the artery next to the long thoracic nerve. Okay, and the long thoracic nerve is from C5, C6, and C7. The thoracodorsal nerve is a posterior cord, innervates latissimus dorsi, crosses the lower border of the teres major to enter the deep surface of the latissimus dorsi muscle. The thoracodorsal nerve is adjacent to the thoracodorsal artery. Here's the serratus anterior plane. Okay, here's the ribs. Here's the plane right here with the blood vessels in it. That's going parallel to the rib. along it. You could see the pleura was moving with the breathing. Here we go, pleura again. When that line stops moving, it means there could be a pneumothorax. That's a normal phenomenon, that moving of the pleura. Okay, serratus anterior is right here. Once again, here's the muscle, here's the plane. Erector spinae. So this is a group of muscles in which you have the intercostalis, longissimus muscles, spinalis muscles. They run you from the spinous process to the ribs. It stabilizes the spine. And the erector spinae plane block here is 2 centimeters away from the spinous process, cranial to caudate needle approach. Contact the transverse process, and you inject 1 to 3 mLs to confirm the plane. You could hydrodissect with saline once again, or you could just give local. Your probe is placed like this, and you're looking at the tissue to see in a longitudinal view. You come in from inferior if you want, and here I'm coming in, and the plane is not just above the bone. I mean, it's right here. There's a plane, but it's easy if you're going out the bone because you won't get any deeper. That's your safety. So here I'm getting into the plane. The pain block is another new fascial plane block for acute pain relief from hip fractures. You're targeting the musculofascial plane between the psoas tendon and the pubic ramus. You're blocking the accessory obturator nerve branches, the obturator and femoral nerves. So you're basically getting the articular branches of the hip. You're blocking them. Here's the iliopsoas tendon. Here's the anterior superior iliac spine. You're below the femoral artery and nerve. It's almost like you're doing a tendon injection of the iliopsoas muscle. Here's your approach. And there's some data backing this up. You can reduce consumption of opioids and NSAIDs for up to 48 hours post-operatively. And I'm going to go backwards, and I realized that because of an issue with memory on my computer, the presentation stopped during part of the peripheral nerve. So I'm just going to go quickly back to the peripheral nerve blocks just to go over a couple slides I missed, and then we'll wrap it up. Any questions in the meantime while this is cooking? Anybody want to add anything? Remember, my disclaimer is I'm doing pain management mainly now. I'm not doing as many regional anesthesias as I used to do. So if there's someone here who has something to add, you're more than welcome to share it with the group. Or not. Okay, just give it a few more minutes or seconds, hopefully. These are large files, so they take a little bit to load. If anybody needs a couple minutes to get up or do something, feel free. I'm sure we'll still be waiting for a little bit. Still here if you have any questions. Just trying to get this thing loaded for you. Okay, got it. Give me a second here. Okay, I'm going to start with the online version of this. So the videos, if they don't play well, I'll just have to convert back the other way. In the meantime, okay, so starting with the occipital nerve block, which you don't really do much in the anesthesia world, but you never know. Somebody has an occipital headache, or if there's a surgery of the net of the head, or let's say the neurosurgeons are placing a ring around the head and you want to anesthetize the cranium, the region. The occipital nerve block can be very useful. And with ultrasound, it's, I think, safer and requires less local anesthetic and hopefully less trauma to the patient. So you locate the atlas and the axis. The C2 spinous process is a bifid spinous process. Locate the obliquus capitis inferior muscle, the lamina, and axis of the transverse process. These are all landmarks, which I'll show you in a second. So here we go. The C2 spinous process is bicornual, meaning there are 2 points here. Okay, your probe is in the midline of the neck, scanning. Okay, once again, the video is not working with that. I'm going to go back to that. Once my presentation is loaded, we'll go back to all the movies, because this is the online version where we don't see the movies very well. But just to move along, supraorbital nerve, it's very difficult to see with the ultrasound, and the ultrasound could actually be in your way. So I'm not a big fan of using the ultrasound for the supraorbital nerve. I've done this one many times blind. The superficial cervical plexus. This is a great block. It works very well for clavicle fractures, for anything in the neck of the fascial planes of soft tissue. It could be useful for the clavicular fractures as well as thyroid surgery. You're getting up to the mastoid process by the lesser occipital nerve all the way down to the clavicle. So it's a very useful block. I've done carotid endarterectomies with just a superficial cervical plexus block. Your target is posterior to the sternocleidomastoid muscle. Okay, this is the coverage of the superficial cervical plexus block. So you can imagine why it's such a useful block. And it doesn't require much local. The deep cervical plexus block used to be, we used to go blind close to cervical foramen. That's not necessary anymore. You have an ultrasound, just go posterior to the carotid artery. Right here is your target. Be careful, of course, right? You don't want to get phrenic nerve or too much or an intravascular injection. The tap block, very useful. The plane is from T7 to L1. It varies depending on the study. Anesthesia to the parietal, peritoneum, and the abdominal wall. It's useful in acute and chronic pain settings. The external oblique, internal oblique, transverse abdominis muscles are here. I've done this for chronic pain. It's, of course, good for any sort of abdominal wall pain. The intercostal nerves range from T7 to L1. The subcostal is T12. The iliohypogastric is L1. Okay, the triangle of Petit, which is the lateral aspect of the abdomen, it's composed from superficial to deep of the fascial extensions of the external oblique, the internal oblique, and the transverse abdominis muscles, respectively, and the peritoneum. So scanning from posterior to anterior in the axilla. Okay, we'll get back to the movies if we can later. Sorry about that. Tap complications, peritoneal perforation, hematomas, femoral nerve palsies. The inguinal nerve is useful for lower abdominal groin pain from surgeries, post-C-section pain. Mainly, we do it a lot for inguinal hernia repair, postoperative, any sort of postoperative pelvic surgeries or lower abdomen. You draw a line from the ACEs to umbilicus, place a probe in that line, you angle towards the posterior lateral direction. Use Doppler to get the vasculature as the nerves are in this plane. You perforate the internal and external oblique muscles, almost like a tap block, and you're aiming for that region. Here's a little movie of that. This is the anterior superior iliac spine. Once again, I'll do the movies after. I inject 4 to 7 mLs of 0.25% bupivacaine or ropivacaine. Don't give too much. You'll get a femoral nerve block. Been there, done that. You want your patients ambulating and going home. So keep it to no more than 7 mLs. The medication will track down over the fascia iliacus. This is a tibial nerve block for a patient getting PRP in the plantar fascia.
So this patient suffering from plantar fasciitis related to a heel spur, I'm going to give her a PRP injection, platelet-rich plasma, to reduce inflammation and promote healing. Prior to doing that, I'm going to give her a tibial nerve block to reduce the pain so that I don't need to put any local anesthetic with my PRP. I don't want anything to interfere with the activity of the PRP. So I'm going to go proximal to the tibial nerve, which innervates the medial and inferior aspect of the foot, and will hopefully give her enough anesthesia for the procedure. So to find the tibial nerve, I'm locating the medial malleolus. I visualize the nerve next to the artery. And one option is to go towards the tarsal tunnel, which is over here. You have Tom, Dick, and Harry, tibialis posterior, followed by flexor digitorum, and then flexor hallucis longus. With the tibial nerve in between them. Another option is to go more proximal for the tibial nerve and follow it up in the ankle. So to the right of the screen, we see the Achilles tendon. We're going to give her a little vapor-coolant spray for skin anesthesia. A little pinch. So as you see, here's my needle. It's surrounding the nerve. The black around the needle is the local anesthetic.
Okay, so I'm not getting into the plantar fascia injection because it's not pain med. And let's go back here. Okay, so see if I could just get those movies for you before we wrap it up. See if now they're playing. Okay, there's a few blocks we didn't really talk about. Peroneal nerve at the fibular head. This is something that's the anesthesia board question of the year. You always get that. This is what it looks like under ultrasound. Here's the fibular head. Here's a peroneal nerve. Okay, just a simple injection. I did this one as a patient who had an injury, a trauma here, and they were throwing opiates at her for years. I just did one block and she couldn't believe it helped. And why didn't anyone do this for me sooner? She asked her previous pain doctors for a nerve block, and nobody did it. I guess they didn't know how to do it. And she was actually a little angry at them after I did the block. She's like, I didn't know you could do this. And she's been suffering for like 8-9 years. So this woman now has a peripheral nerve stimulator on this nerve, and she's doing okay. Here's the image once again. You're looking at the side of the leg by the fibular head. Here's a cross section of the nerve. Intercostal nerve block's a big one. One of the oldest nerve blocks we've been doing since 1907. You can inject local anesthetic, steroid, or alcohol or phenol for neurolysis under the rib. There are 12 pairs of thoracic spinal nerves, T1 through 12. There is ventral and dorsal rami as they pass through the intervertebral foramina. The ventral rami of T1 through T11 forms the intercostal nerves and enter the intercostal space. The ventral ramus of T12 forms a subcostal nerve located inferior to the 12th rib. These are the ways you would hold your probe. You could go in plane, out of plane, or you could go longitudinally or get a cross section of the nerve. And the nerves actually are supplying the sensation of the skin, muscles, bones of the back. Dorsal horn sensory afferents, ventral horn motor efferents, and postganglionic sympathetic nerves are here. The major branch of the intercostal nerves are the anterior lateral cutaneous branches. So this is one of those nerve blocks where you get paradoxical, I guess, retrograde anesthesia, meaning you'll do a distal block and get proximal anesthesia as opposed to doing a proximal block and getting distal anesthesia just because the nerve loops back around. The blind procedure you can just do with palpating the ribs between your two fingers, and you insert to bone, you pull the skin down a little bit, you walk a few millimeters past the rib, aspirate, there should be no blood or air, say a prayer that you're not in the lung, and inject. But of course we have an ultrasound, so don't do that. You could just use the ultrasound. It's a lot easier, and I'll show you how easy it is. So once again, this is the angle that you could take. This is what you're looking at, a cross section of the rib with the nerve artery vein. The lung is right there, so please be careful. Ultrasound is pretty available these days, especially with the smaller, cheaper units that give good visualization. There's plenty of studies to support this. So here's what it looks like. You have the intercostal nerve under the rib. It's a cross section. Here's the intercostal muscles. Here's the pleura. Very close together, so be very careful. Pneumothorax is, of course, the big complication that we mainly worry about, in addition to all the usuals, infection, bleeding, allergy. Here's an old video, but it should, get my point across. You have to keep your needle in plane in sight. You do not want to leave sight of your needle tip. And you want to visualize medication spread. Okay, paravertebral nerve blocks was very popular early in the 20th century, then fell out of favor. Then back in the 70s, it became popular again. We were doing the blind techniques when I first started, but then with the ultrasound, it's been a lot easier to find what you're looking for. You could do this for open thoracotomy, video-assisted thoracic surgery, breast surgery, minimally invasive cardiac surgery, renal surgery, choles, open or closed, appendectomy. I mean, you're getting the somatic and visceral fibers with this. You're very close to the spine, so you'll get some of the sympathetic nerves as well. I'm using this also for post-herpetic neuralgia, post-thoracotomy pain syndrome. I'm not doing this for maternal labor, but I guess some people are. Pain from mesothelioma. I've never seen a mesothelioma in my whole career. You'd think they're so common with the way the lawyers talk about it, but I never seen one in my practice. Sympathetic blockade, therapeutic control of hyperhidrosis. I haven't done it for that, but I've heard of people doing it. So posteriorly, you have the superior costal transverse ligament, which is a continuation of the intercostal muscle. Anterior laterally, you have the parietal pleura. Medially, you have the vertebral bodies, the intervertebral foramina, and the intervertebral discs. Thoracic paravertebral space is a triangular or web-shaped space running the length of thoracic vertebral column bilaterally. In contrast to the cervical and lumbar regions, the thoracic paravertebral regions in continuity with the adjacent vertebral levels, allow for spread up and down of the local anesthetic. Okay, here's what it looks like. Okay, it's a triangular wedge-shaped space. Okay, you're going between the lung and the spine. You could do it with the patient sitting, standing on their side. I wouldn't do it with them standing. You could have them upright, I mean. And I normally give anywhere from 3 to 5 mLs per level. You don't really need to do so much unless maybe you're doing a surgical case. But for postoperative pain, I don't really need too much. So loss of resistance can be appreciated once you get into the space. You want to aspirate and then you can inject. You might want to give a test dose. So with everything fading away here, you see the ultrasound image, okay? And here's the pleura, here's your target. This is the lamina or transverse process, depending on where you are, the spinous process. Okay, here's the lung moving. And you don't want to see too much bone over here. You can scan up and down to make that bone disappear to get right here to that wedge-shaped spot. This is where you want to be. And the needle's coming in right here. There's your pleura and your target. Okay. Here are the complications. Pretty rare, actually. Failed block, hypotension, vascular puncture, pleural puncture, pneumothorax. Okay, here is patient in plane again. Sometimes if you do a rectus spinae, you can also do the paravertebral in the same patient. It depends on really what your goals are for the case. I'm anesthetizing soft tissue, and then I'm getting into the erector spinae plane, and then into the paravertebral space, which is right here. And you can see how the transverse processes are flatter than the ribs. They're more round. So when you're doing the erector spinae block, you want to look for flat transverse processes like this. So I'm going to go back one more time. Okay, and this is the target right here for the paravertebral block in plane. Erector spinae is up here. There you go. And then I went deeper to the paravertebral plane. Okay, there's lots of data out there supporting the use for breast surgery, tumor resection, using it in children. For multiple rib fractures, it's great. Patients who have problems with the hip, avascular necrosis, getting a paravertebral or erector spinae plane block around L1 or L2. I've done the ESP blocks at L2 for the hip surgeries. It's been useful. For cancer, people doing neurolysis. And that occipital nerve block video is finally here. So you get the bifid spinous process in view, and you scan laterally, you see the transverse process, and the nerve is between the two muscles, obliquus capitis inferior and the spinous capitis muscle, which is more superficial. Okay, and I believe we covered most of this. I just want to make sure there's no videos I've missed. Yes, we did. So here's that tap plane that we're scanning from posterior axillary to more anterior axillary. And we're looking for the muscles. By the way, that was a QL muscle right here, right? And here's the plane. Here's the fascia, transversalis fascia, transverse abdominis muscle. The internal oblique's a thicker muscle. External oblique's up here. And the plane, you can even see like the nerves, these little round ovals are nerves. And the patients will get paresthesias when you get into this plane often, if you're doing this with them awake. Subcostal tap, very similar to an intercostal. Here's the rib, the last rib, and you're just aiming as if you're doing a tap block right here. Here's the plane. So you can always get a bowel perforation if you're not careful. I think you saw the rest of the videos. And I'm going to just put up the slides to sum up the whole presentation. If there's any questions, please feel free to ask. Okay, the CME credits, if you didn't claim them yet, you just need to text let me just grab that information up here. There's a phone number to text. Just take this down. I don't have the slide up, and it'd be a lot quicker to just tell you. So text the word 75, F-O-R-D, lowercase, 75 Ford, like the car, to 828-295-1144. Once again, text 75 Ford to 828-295-1144, and you'll get CME credits for this activity. So we do have a question. Good question. Do I do the ilioinguinal block from a lateral or medial approach? Okay, that's a great question, and I didn't really focus on this much. The problem with the ilioinguinal block is you're very close to the anterior superior iliac spine. And many times I've struggled getting my needle between the probe and the anterior superior iliac spine. The best thing I can advise you to do, if you have the capabilities, which many of you probably don't have, I used to have it, was a device, an ultrasound with something called B-steer, which, if you're not familiar with what B-steer is, it's taking, here, let me just put on my my video so you could see what I'm doing here. So B-steer takes the ultrasound crystals and it just changes the alignment of them. So you're not moving the probe, but you're moving the crystals and how they view the tissue. So imagine if you're going over here and you want to go more laterally, move medial, but focus laterally. You could steer the crystals laterally. So what I'm doing instead is I'm taking the ultrasound, I'm going like this and I'm pushing very hard on the patient. It'd be a little uncomfortable, but it enables me to get between the anterior superior iliac spine and the probe to do a lateral to medial approach and get the nerves. Now, you could do a medial to lateral approach. I just always found this to be easier, and I never even tried to do medial to lateral. This is just how I learned to do it. So if someone else has something to add to that, I'm more than happy to share it with the rest of the group. But I find that the B-steer helps. If you don't have B-steer on your ultrasound machine, just angle it, and that should help. Are there any other questions? So we're doing a ultrasound course April 18th. Once again, I'm doing that with WATMU possibly. If not, I might be doing it alone. I'm not really sure yet. But the venue has not been set because the venue that we originally were doing went out of business because of the pandemic. It will probably be in Manhattan on a Sunday, most likely a full day, small chance a half day, we'll see. And it'll be a model course, no cadavers. And I hope to see you guys there. If you're interested, shoot me an email or just subscribe to the PainExam newsletter. You'll get more info there, or the PainExam website, or painexam.com/events. And I want to thank you all for spending the day with me. And feel free to shoot me an email if you have any questions. Take care.